Hear me? Okay. Good evening, friends. So finally the wait is over, and we're going to be starting our much-awaited masterclass on impulse oscillometry, which is then going to be followed. By he's an authority on impulse oscillometry. So Dr. Sandeep Salvi will be giving us about a 40 to 45-minute talk on iOS, and then we'll move forward and we'll have a wonderful panel discussion from our esteemed panelists. Over to you, Dr. Sandeep Salvi. Looking forward.
Thank you. Thank you very much, Dr. Amita, for those wonderful, kind words of welcome and introduction. Wish you all a very good evening and welcome to this Sunday evening webinar on oscillometry. I think this is indeed one of the important webinars, at least for the forthcoming years, because I genuinely believe that lung oscillometry is going to be the future of lung function testing, and therefore it is important to sensitize all doctors about this. It's not an old device. It's not a new device. It's an old device that was introduced way back in 1956, but it has indeed taken some time for it to start getting recognized as an important diagnostic tool for lung function. What I'm going to do over the next 40 minutes or so is to give you a brief overview about what oscillometry is, what are the fundamental principles that we must understand. And then once our fundamental principles are very clear, then we can start applying that knowledge in interpreting the results of this so-called novel and important diagnostic tool. We all know that spirometry is the gold standard diagnostic tool for lung function as of now. However, this very important diagnostic test needs a very special maneuver. We need to put an effort while doing this test. And it is important to first understand the challenges when we perform spirometry. If you look at the first volume that we measured in a lung function, which is tidal volume, if you look at the difference between a healthy individual and a person who suffers with obstructive airway disease, whether it be mild to moderate or whether it be severe, the tidal volumes are exactly the same. So measuring tidal volume does not give you any signal to differentiate between health and a disease state, such as obstructive airway disease. Similarly, if you look at vital capacity, and especially if you look at slow vital capacity, the ability to distinguish between a healthy state and an obstructive airway disease state is also not very good. So if you look at the difference between mild to moderate obstructive airway disease versus healthy, there is hardly any difference between the two. And only when you have very severe obstructive airway disease, there could be a slight decrease in your slow vital capacity. So your slow vital capacity also does not offer any ability to distinguish between health and a disease states. Forced vital capacity, on the other hand, seems to show a little more sensitivity in picking up disease only when it is severe. So when you have mild to moderate obstructive airway disease and you compare the forced vital capacity between a healthy and a patient with mild to moderate obstructive airway disease, there's no change at all. However, a patient who has got severe obstructive airway disease, there is a drop in the FVC, but you can only see that signal in a severe form of obstructive airway disease. So forced vital capacity on its own also does not offer a very good signal to differentiate between health and obstructive airway disease. On the other hand, if you look at FEV1, that seems to be a very good parameter that distinguishes between healthy, mild, moderate, and severe obstructive airway disease in a dose-response manner. So FEV1 was found to be the only parameter that was useful in diagnosing obstructive airway disease and in determining the severity of the disease. So when spirometry was first introduced in 1846 by by who discovered spirometry? So by Hutchison. When Hutchison discovered spirometry in 1846, the only parameter that he measured was vital capacity. It took 100 years, 1946, for the FEV1 to be introduced. And the FEV1 then gave a good signal to differentiate between health and obstructive airway disease. So what is so important about spirometry? It is a forceful maneuver which is necessary to make a diagnosis of obstructive airway disease. If you do not do a forceful maneuver, you will not be able to distinguish between health and obstructive airway disease. Moreover, in this test, you have to take a deep inhalation before you exhale your entire vital capacity out. But that deep inhalation on its own causes bronchospasm, especially in patients with asthma and in some patients with COPD. So while performing the maneuver itself, it is going to give you bronchospasm even before the test is actually performed. So there are limitations to this. And then finally, it is a challenging test to perform. The forceful maneuver causes bronchospasm. The forceful maneuver itself causes bronchospasm. And finally, only about 50 to 60% of the patients are able to do a good quality spirometry. No matter how good you are, or no matter how good your spirometry technician is, it is a challenge to get good quality spirometry in all the patients. So it is with this background that oscillometry has now evolved as a much more simpler, much more sensitive, and a tool that gives you a lot more information than what spirometry offers. If you look at the spirometry indices, you have the volume time graph and the flow volume loop. These are absolutely crucial when you want to make an interpretation of the report. And then these are the parameters, the two volumes, your FEV1 and FVC, the ratio between the two volumes, then the two flows, the PEFR and FEF 25 to 75. So these are the fundamental 5 parameters that we require in spirometry to make an interpretation. Above that, we need these 3 additional parameters that will give you more useful information. FET and FIVC will give you the quality of the report. And FEV3 by FEV6 is now recognized as an important parameter that diagnoses small airways obstruction. So other than FEF 25 to 75, you could also use FEV3 by FEV6 as a marker for small airways obstruction. So these are the parameters that we use in spirometry. Do we use the same parameters in oscillometry? No, we don't. So what is oscillometry? What is the first name that it was given? So the mother name that this test started was called as FOT, a forced oscillation technique. Why is it called as forced oscillation technique? Because you're forcing oscillatory pressure waves of different frequencies into the mouth while you're doing normal tidal breathing. So you're forcing oscillatory pressure waves while you're doing normal tidal breathing into your respiratory tract. And the output that you're measuring is a change in the pressure and the flow. So change in the pressure and the flow are the only 2 parameters that are essentially measured in this test. Now, the oscillatory pressure waves that we are forcing into the respiratory tract are of different frequencies. They start from 5 hertz and they go up to 30 hertz. It can even go up to 35 hertz. So these are the frequencies of oscillatory pressure waves that are pushed into the respiratory tract, or they're forced into the respiratory tract during normal tidal breathing. And therefore, this test is called forced oscillation technique. The oscillatory pressure waves can be generated by different mechanisms. For example, you can generate the oscillatory pressure waves by a loudspeaker. So the loudspeaker generates sound. Sound is a pressure wave of different frequencies. You can also generate oscillatory pressure waves through an alternating piston. So a piston that goes forward, backward at a specific rate, and that will generate specific frequency pressure waves. Or you could generate that by a piezoelectric vibrator. So these are the 3 different sources by which you can generate these oscillatory pressure waves. Now, forced oscillation technique can be divided into 3 categories or into 3 groups. What are these 3 groups? monofrequencies, impulses, and pseudo-random. What is monofrequencies? In monofrequencies FOT, you pass in pressure waves, individual frequency pressure waves. So you'll start with 5 hertz, you'll push in 5 hertz of pressure waves, then you'll turn the knob, go to 10 hertz, then to 15 hertz, then to 20 hertz. So you do individual frequencies, one after the other in a sequential manner. So this is FOT using monofrequencies. You could also use impulses of sound waves or pressure waves. Impulses, especially what is used in what we now call impulse oscillometry. Here, a mixture of all these frequencies, mixture, 5, 6, 7, 8, 9, 10, right up to 30. That entire package of all the frequencies is forced inside the respiratory tract as an impulse. So that is another way of doing this test. At one time, all the frequencies go in. In monofrequencies, they go sequentially, 5, 10, 15, 20. And finally, you have the pseudo-random one. In the pseudo-random noise FOT, we use prime numbers. What are prime numbers? These are numbers that cannot be divided by any other number. So 5, 7, 11, 13, 17, 19, 23, up to 29. So in pseudo-random, these frequencies of these different numbers are then forced into the respiratory tract. So each one of them is called as an FOT. So monofrequency is called as an FOT. Impulses is called as an FOT. Pseudo-random is also called as an FOT. The tool that was first launched in 1976 as a commercial tool for measuring FOT was a device developed by Jaeger called Impulse Oscillometry System. So Impulse Oscillometry System was the first device. And therefore, the name got stuck, and we seem to be calling all FOT devices as impulse oscillometers. The answer is impulse oscillometry is one type of FOT that pushes in these oscillatory pressure waves through pulses. Now, very interesting. If you look at the originators of the photocopying machine, they were the Xerox machine. So because they were the innovators, when you made a photocopy, you called it as a Xerox, because the machine was first developed by Xerox. Now, the same photocopying machine is developed by Canon, Fuji, Ricoh, Konica, Sharp, Toshiba. But then we still call it as a Xerox. Please go and get a Xerox from this machine, whether it be a Canon machine or whether it be a Toshiba machine or a Sharp machine. Because that name got stuck, everything seems to be called as iOS, just like how the Xerox is called for even if you do a photocopy with other machines. So what should be the correct name of this test? I suggest that we all should call this test as lung oscillometry test. FOT seems to be a very generic term that does not explain everything, but a lung oscillometry should be the correct name for this test. So whether you use impulse oscillometry, whether you use monofrequency, or whether you use pseudo-random noise, we should all call this test as lung oscillometry test or LOT. Ideally, it actually measures respiratory, it measures the respiratory function. So the correct word, scientifically correct word, should be respiratory oscillometry test. But then, the acronym becomes ROT, which is ROT. Doesn't sound well, and therefore, many people believe that the correct term should be LOT, lung oscillometry test. So stop calling your test as impulse oscillometry or FOT. Start calling it as lung oscillometry test. Now, one of the key features of the fundamental principles on which a lung oscillometry system works is this very important observation. Sound can be generated with different frequencies. So here is a very old radio where we used to have the old AM radios. We don't use AM radios anymore now. We use only the FM radios. But the AM radios, they were very low frequency, 1 megahertz, but they had the ability to travel up to thousands of kilometers. So if you went to an AM station, and the same station could be played all over the country, whether it be Delhi, whether it be Chennai, whether it be Kolkata, or whether it be Rajasthan. The same radio station could be played at all the places because AM sound waves, they travel long distances, up to thousands of kilometers. In contrast to that, the FM radio, which is frequency modulation, they use a very high frequency sound, about 100 megahertz, 100 times more than the AM radios. And because they use very high frequency, the distance that is traveled by the FM radio is only about 50 kilometers. So Pune radio FM, Mumbai radio FM are they completely different because these radio stations, they travel only shorter distances of time. So what is the important message that I'm trying to convey to you? Sound waves of shorter frequency travel longer distances, and sound waves of higher frequency travel shorter distances. Now, why is this relevant for us, from a clinical setting, from an oscillometry setting? I'm sure all of you all would have ordered your patient to get ultrasound, USG. Now, depending on which part of the tissue you want to examine, you use ultrasound with different frequencies. So if you want to go deep into the abdomen and get your images from there, then you need low frequencies, 2.5 megahertz. As the frequency increases, then the depth of those ultrasound becomes lesser and lesser and lesser. So if you want to measure the thickness of the cornea, or if you want to measure the thickness of the epidermis, then you use very high frequency ultrasound. So again, what is the message over here? The shorter the frequency, the deeper it goes. The higher the frequency, the more superficial it goes. And the same principle is applied in oscillometry. So the low frequency, which we start with, which is 5 hertz, the low frequency travels the entire respiratory tract, right up to the alveoli. The higher frequency, which is 20 hertz, this travels for a shorter distance. So it goes only up to the large airways. So frequency of 5 hertz travels the entire respiratory tract, goes deep into the lung. 20 hertz goes only up to the large airways. Now, the beauty of this is, if you subtract the resistance from 5 hertz and 20 hertz, you specifically get the resistance that is present in the small airways. So R5 minus R20 is a very, very useful parameter that tells you what is happening in the small airways. So because of the different frequencies that are used in oscillometry, we can actually target different portions of the respiratory tract. So if you want to look at what is happening in the large airways, then you can use both 5 hertz as well as 20 hertz. If you want to target what is happening at the small airways, you can use 5 hertz and then you can use R5 minus R20. R5 minus R20 will give you very specific information about small airways. So I think it's important to understand why we are passing in sound waves or oscillating pressure waves of different frequencies. Because we want to study the resistance pattern at different levels of the respiratory tract. Now, before I go into this, I think it's important for all of us to appreciate the beauty of this wonderful organ called as the lung, whose prime function is to nourish the body with oxygen. Each one of us needs 1,000 liters of pure oxygen every day. And this oxygen that this lung provides us with generates 90% of the body's energy. Only 10% of the energy comes from the food that we eat and the water that we drink. So the oxygen that is nourished by the organ is the most important nutrient that keeps us healthy and it keeps us alive. In addition to that, the lung also plays a very, very important function of excreting a very, very large number of waste product called carbon dioxide. It excretes about 350 liters of carbon dioxide, which is produced when you utilize oxygen to produce energy. So the waste product has to be excreted. And imagine if this excretory portion of CO2 was entrusted upon the gastrointestinal system or the renal system. I believe, out of 24 hours, we would be spending most of the time in only excreting CO2, but the lung has taken up this responsibility of excreting it through the breath. So it's a very large number of CO2 that needs to be eliminated. So in order to do this function, we need to breathe around 20,000 times a day. Every minute we breathe around 15 times. So if you add up all that together over 24 hours, it comes to around 20,000 times. And during that period, we inhale and exhale about 10,000 liters of air. Out of these 10,000 liters of air, the lungs soak in about 1,000 liters of oxygen and push it into the circulatory system. They take in 350 liters of carbon dioxide and throw it out. So breathing is an activity that does this role. With each breath that we take, we pull in about half a liter of air. And this volume is called as tidal volume. Now, in order to do all this, our lungs need to work very hard, isn't it? We have to pull in 10,000 liters of air, extract 1,000 liters of oxygen, throw away 350 liters of carbon dioxide on a daily basis. The amount of work that it must be, amount of energy that it must be spending must be quite large, isn't it? Now, if you look at the work of breathing, it's a very, very fascinating physiology. So the normal tidal breathing that we do, the breathing just like the tidal waves of the sea, in, out, we do it unknowingly. Half a liter of air through each breath. The air that remains at the end of tidal volume, which remains inside the lung, is called as the functional residual capacity. And the functional residual capacity, which is around 3 liters, is physiologically the most important air, a volume of air inside our lungs. Not the tidal volume, not the vital capacity, but a functional residual capacity. The most important physiological lung volume. And I'll tell you why. If you look at the anatomy and the structure of the chest wall, the chest wall is always wanting to go outwards. And the lung parenchyma, which is made up of a lot of elastic tissue, always is wanting to go inwards. So the lung wants to go inwards, chest wall wants to go outwards. Now, these two opposing forces are perfectly balanced at the functional residual capacity. So at FRC, the outward movement of the chest wall and the inner recoil of the lung parenchyma is exactly equal. Two opposite and equal forces. Why am I telling you this? Because when you have two opposite and equal forces like this in a lift, so this is the lift through which we go inside, and this is the lift chamber. There's a rope goes, there's a pulley, and then at the other end of the pulley, there's a weight that is attached. The weight is this weight that is put over here is exactly the weight of this. So the gravity can help when there are two opposite and equal forces. Then gravity can assist enormously in enhancing the efficiency of the lift. What do you mean by that? So when you sit inside the lift, when you press the button to go on the 5th floor, you only need to kickstart, the motor to start going upwards. So the amount of electricity that is consumed in making that lift go up is very, very little, because then the weight on the other side is actually taking it up. The weight is going down and the lift is going up. So the amount of electricity that you spend in a lift is very, very little. That's because of these two opposite forces. So that's the amazing principle that even the lung utilizes. During inhalation, the diaphragm contracts, the alveoli expand, and there is energy required to do this. But the energy is required only for the inhalation process. Exhalation is a completely passive process for which no energy is spent. Because of your inhalation, the alveoli become enlarged, and because there are elastic structure, they want to come back to their original position. And because of this elasticity, the alveoli start closing in, which causes our exhalation, but no energy is spent during exhalation. Energy is spent only during inhalation. That's the beauty of this organ. Breathing accounts for only 1 to 2% of the body's energy that it spends on a daily basis, just because of this super efficient process of two opposite and equal forces of the chest wall and the lung parenchyma that makes the lung spend very, very little energy. That's the beauty of this wonderful organ called as the lung. It's a super efficient organ at functional residual capacity. Now, why is functional residual capacity the most important physiological lung volume? So here it is. So here is the elastic property of the lung. This is the weight that is required to move this. You can see that in a healthy lung, the go inhalation, exhalation. Inhalation is because of the mass that is pulling it. Exhalation is because of the elastic properties of the coil over here. So FRC is right in the middle here. Lung elastic recoil and chest wall elastic recoil. They're two opposite forces. And FRC is right in the middle. The amount of energy spent is very little. In COPD or emphysema, When the weight becomes big over here, the you know the elasticity of the spring becomes less. The chest wall elastic recoil becomes more powerful in COPD compared to the lung elastic recoil. So the FRC now shifts to the right. Now this means that you have to spend additional amount of energy in removing the air out, because in COPD and emphysema, the lung alveoli become damaged and destroyed. They don't come back to their original position because of the lack of elasticity. So to exhale, then you have to spend energy in pushing the alveoli, the air from the alveoli out. And exactly the same thing happens in interstitial, exactly the opposite thing happens in interstitial lung disease. It becomes a very thick, the elastic recoil is very, very strong over here. So the lung elastic recoil becomes more powerful than the chest wall elastic recoil. FRC now shifts to the left, and now you need to spend more energy in taking an inhalation as compared to removing the air out. So at FRC, inhalation exhalation is very easy. During emphysema, exhalation becomes more difficult, and during pulmonary fibrosis, inhalation becomes more difficult. Now, it is important to understand this physiology, because this will tell you how oscillometry gives you this very important piece of information, which spirometry does not. Now, for the gas to reach the alveoli, so the tidal volume, the air, 500 ml of air, to reach the alveoli, it has to pass through the airways until it reaches the alveoli where the gas exchange takes place. Now, all the forces that impede or oppose the passage of the air up to the alveoli, all those forces together are called as impedance. Okay, so impedance is the collective opposition for the passage of the air up to the alveoli. However, this impedance can be divided into two components. The first component is the resistance of the airways. Depending on the radius of the airways, the resistance of the for the passage of the air is determined. Now, the large airways, which are from trachea onwards to the 7th generation, they're called as the large airways. You can see that the airflow is not laminar; it is turbulent airflow, and the resistance is 1 upon r raised to 5. From the 8th generation onwards, which are the small airways, the airflow becomes laminar. So small airways, airflow becomes laminar, and the resistance now decreases from 1 upon r raised to 5 becomes 1 upon r raised to 4. So large airways resistance, small airways resistance, which needs to be overcome for the gas to travel right up to the alveoli. Now, this resistance offered by the frictional forces of the airways is called as resistance. This is obviously related to the flow rate, and because it is frictional resistance, that energy that is spent is lost as heat. So that whatever energy is spent is gone. Now, in addition to resistance, there are other opposing forces that need to be overcome. What are these? So one is the inertive properties of the lung. What do you mean by inertive properties? So at FRC, there is 3 liters of air inside the lung. Now that 3 liters of air also has some mass. So the half a liter of air that you breathe, which is a tidal volume, it has to overcome the weight of the 3 liters of air that is there in your lungs. And that is called as the inertance of it has to overcome that inertance of the weight of that air column. Also, the alveoli are elastic. So to open up the alveoli, it has to overcome those forces of elasticity, isn't it? So that force that is spent in opening up the alveoli for the air to reach up to the alveoli, that portion is called as capacitance. It measures the elasticity of the lung or the compliance of the terminal portion of the lung. So these two forces, which is inertance and capacitance or elastance, whatever you call them, these two forces are called as reactance. Resistance is only for the airways. Reactance are the inertive properties, which is the weight of the air, weight of the FRC in the lung, and elastic properties is your capacitance. So reactance is a combination of inertance and capacitance. It's important to understand this because oscillometry is all about resistance and reactance. And reactance has got two components, inertance and capacitance. So somebody wanted to measure resistance and reactance, but nobody actually came up with a bright idea. In 1827, George Ohm came up with this Ohm's law, very, very fundamental law. And he made this law for the passage of electric current. Voltage divided by current is equal to resistance. Okay. And then it was found that the principle that we use in an electrical circuit can also be used in a flow. If there's a flow of air or this flow of water, pressure, flow, resistance. So pressure divided by flow is equal to resistance, which is derived from this electrical circuit formula. Voltage divided by current is equal to resistance. Now, the resistance that is offered for the passage of air up to the alveoli can now be measured if you know these two parameters, pressure and flow. And then in 1800, before George Ohm talked about his Ohm's law, Volta from Italy, he actually discovered the direct current, electrical current. So there's a direct current where electric current flows only in one direction, in this direction. There is a resistance for the passage of the current because of the the wire that we use. Now, voltage and current, they seem to go exactly parallel to each other in a direct current. Voltage upon current. So the resistance is, which is V upon I is equal to R, which is usually closer to 1. Now, unfortunately, the respiratory tract does not work like a direct current. The respiratory tract, because of inhalation and exhalation, works like an alternating current, where the air goes in and out. Now, in an alternating circuit, you have a resistance, but unlike a direct current, you also have opportunities of having these two electronic components. One is a capacitor and one is an inductor. Exactly the same parameters that we wanted to measure in airway reactance. So a capacitor is a device that stores electrical energy in an electrical field, and it opposes the change in voltage. I'll tell you why this is important. On the other hand, an inductor also stores energy, but it stores electrical energy in a magnetic field, unlike the capacitor, which stores it in an electric field. And an inductor opposes the change in current. Now, let me explain to you this opposing the change in voltage and opposing the change in current through a graph over here. So when the voltage and the current go exactly parallel to each other, we are still measuring resistance. But if the current goes ahead of the voltage, or the voltage is lagging behind the current, we still have the voltage and the current, but now we have a phase shift over here. There's a little bit of a lag for the voltage to reach. This is what measures the capacitance. And exactly the opposite of this is when the voltage goes ahead of the flow, then we measure what is called as inductance. So if you have to measure resistance, capacitance, and inductance, we just have to follow this simple principle that an alternating circuit uses. And based on just two parameters, now this is electricity. So here we replace that with pressure, flow. Are there only two parameters that are required? But we can now measure capacitance and inductance depending on who goes ahead of what. And who goes ahead of what is now dependent on the frequency of sound waves or the frequency of oscillatory pressure waves that you use. Let me explain that to you. Arthur DuBois, I believe he's a genius in the, genius pulmonologist of our times. Born in 1923, just died very recently at the age of 95. He was an amateur radio operator since the age of 15. He was very, very famous. He was very, very good at operating a radio. So he knew everything about resonant frequency. He knew everything about capacitance. He knew everything about inductance. He knew everything about resistance. Now, he applied that knowledge in measuring resistance, capacitance, and inductance in a respiratory tract using the same principles that are used in an electronic circuit. Change upon pressure divided by flow is equal to resistance, which was the Ohm's law. But see, he was called as the king of pressure and flow, Arthur DuBois. And in 1956, he discovered two important diagnostic tools for respiratory medicine. One was the body box plethysmography, and the second was the FOT. Both of them were discovered by this one single person called Arthur DuBois. Both the papers were published the same year. Now, see, this is pressure and flow. As you can see, pressure is in blue, flow is in red. Whenever the pressure reaches a peak, flow also reaches a peak. Whenever the pressure reaches an ebb, flow is also reaches the ebb. Exactly goes parallel to each other. They go at the same speed. So this pressure and the flow are exactly at the same. They're going at the same speed. This is what measures resistance. Now, if one of those goes ahead, and here you can see that the flow is going ahead of the pressure. Red line is ahead of the blue line. Flow is going ahead of the pressure. This measures the elastance properties of the lung. And when the pressure goes ahead of the flow, that measures the inertance properties of the lung. Now, it is important to understand this. Why do we get three different parameters in oscillometry? We get resistance, we get reactance. Reactance is elastance or capacitance, and inertance. Now, just to tell you, I mean, the devices that have so far been developed for measuring resistance and reactance, the first tool, the first machine that was developed was by Jaeger, and now it's owned by a company called Wire, and this is the impulse oscillometry, first developed in 1975. It almost had a monopoly for more than 30 years. Then came the TremorFlow, then you have the PulmoScan, then you have the MOST graph, and then more recently we have three devices from our own Indian company called iCaltech based in Bangalore. We have the Antlia device, which uses monofrequency. They have also developed another device called Antlia Plus, which uses pseudo-random noise, exactly the one that is found in TremorFlow. And then another device called as Antlia Mini, which measures single frequency. So these are just some of the Oscillo FOT devices that are available in the market. But by and large, there are 10 of them that are there in the market. About 6 years ago, there was only one FOT in the world, was the impulse oscillometry. And for the last 5 to 6 years, look at the number of devices that have come in the market. So the impulse oscillometry measures a speaker to generate the oscillating pressure waves. Antlia uses an oscillating pump. PulmoScan uses a speaker. TremorFlow uses a vibrating mesh, and so on. So the first four are available in India. The MOST graph is available in Japan, and these others, I think Respond Pro is now started becoming available in India as well. So there are at least 5 different oscillometers that are available in India. So oscillometry is all about pressure and flow. Just the last revision slide before we go into the clinical application. So pressure and flow, when they go exactly parallel to each other, we measure pure resistance, and it's a positive number. Pressure divided by flow is equal to resistance. Now, when the flow goes ahead of pressure, pressure divided by flow is still resistance, but now because there's a phase lag over here, we call it reactance. Now, this reactance, because flow has gone ahead, pressure divided by flow, it becomes a negative value. So that compliance or elastance becomes a negative value, purely because flow has gone ahead of pressure. Now, when the pressure goes ahead of flow, you still measure resistance. But because of the change in the phase over here, we call this as reactance. So when there's a phase shift, we call it reactance, like over here. And when they're exactly in phase, we call that resistance. When flow is ahead, it's a negative number. When pressure is ahead, it's a positive number. So compliance or elastance is always a negative number. Inertance is always a positive number. I think it's important to understand why do we get these numbers. So let's go one by one into the respiratory resistance and the two respiratory reactances. So if you look at the entire respiratory tract and you measure the resistance, so from the chest, from the nose up to the vocal cords, they contribute to 66% of your respiratory resistance. So the chest wall, nose, and your upper respiratory tract up to the vocal cords, they contribute to 66% of the respiratory resistance. The large airways, which is from the trachea to the 7th generation, they contribute to 20%. The small airways, which is from the 8th generation to the 23rd generation, the small airways, they contribute to only 7% of the total respiratory resistance. And then finally, the elastic, expansion of the alveoli, that also contributes to 7% of the total resistance. Now, it is therefore important to appreciate that the small airways, they contribute very, very little to the total respiratory resistance. What is the application of this? Because they contribute so little to the total respiratory resistance, until a large number of small airways get damaged or destroyed, you will not start manifesting with symptoms. So if you're a smoker, you smoked for 20 years, no symptoms at all. Does that mean that there is no damage that has happened into your lungs? Of course not. The small airways have got damaged, but you need to have minimum 50% of the small airways to get damaged before you start manifesting with symptoms. Then we will start doing a spirometry, and that's where your parameters will start showing positive values. However, even before the FE1 upon FEC ratio falls less than 70, there's a lot of damage that has occurred in the small airways, which spirometry unfortunately does not measure it very sensitively. So oscillometry, lung oscillometry, can pick up small airways obstruction even before the symptoms come, even before the spirometry FE1 upon FEC ratio becomes less than 70%. That's the advantage of knowing this from an oscillometry point of view. Now, the second one is compliance. The alveoli have to expand. Now, let me explain that in a very simple manner. 1 unit of pressure, say 1 centimeter water pressure, when you put inside, the alveoli expand by around 200 ml. This is normal lung compliance. 1 centimeter of water opens 200 ml. Increased compliance, the same amount of pressure, 1 unit of pressure, now expands bigger volume of air, more than 200 ml. This ability to expand more volume of air for the same unit of pressure is called as increased compliance. And increased compliance is seen in emphysema and aging because of the damage and the destruction of the alveolar walls. Elasticity goes away, but the compliance increases. 1 unit pressure, the lungs become ballooned in size. They don't come back to their original position because of reduced elastance. In what is reduced compliance? The same amount of pressure causes lesser than 200 ml expansion in your lung volume. This is called reduced compliance. And this happens in pulmonary fibrosis and pulmonary edema and acute respiratory distress syndrome. So compliance, normal compliance, increased compliance, reduced compliance can all be measured by oscillometry. And I'll show you how. This cannot be measured by spirometry. And therefore, this is one of the unique advantages that oscillometry has. It gives you information about respiratory compliance. And then respiratory inertance, finally. 3 liters of air, which is your functional respiratory capacity. The 3 liters of air, it weighs 3.7 grams, which is the weight of this pen drive. So 1 pen drive is the weight of that 3 liters of air. So you have to overcome that when you're doing your inhalation and exhalation. So that weight of air, that column of air, that offers the impedance, the obstruction is called inertance. Now, if you replace this 3 liters of air with 3 liters of helium, same volume, but the density is now less. So the 3 liters of helium weighs only 0.5 grams. It's going to make your breathing a lot more easier. And if you go to YouTube, you'll see a lot of these very funny videos on where people inhale helium through the balloon and then they start talking. They got a very funny voice because that helium doesn't vibrate the vocal cords as much as what the weight of normal air does, and therefore your quality of sound is so different when you start talking after inhaling helium. So that also gives you the value of the weight of that air is also so important for during your breathing purposes. So here is the bottom line. When you perform an oscillometry test, you get a graph called as an oscillogram. The oscillogram comprises of 2 components. One is the respiratory resistance component, and one is the respiratory reactance component. Okay. So the respiratory resistance is a positive line, and on the x-axis are the different frequencies. So 5 hertz, 10 hertz, 15 hertz, and 20 hertz. You can even go up to 30 hertz if you want. So the resistance that you measure at 5 hertz is called R5. The resistance that you measure at 20 hertz is called as R20. If the resistance that you measure at 10 hertz is called R10, R15, and so on. Now, what is important to realize is that look at the resistance at 5 hertz, 10 hertz, 15 hertz, 20 hertz. It seems to be uniform, isn't it? So no matter what frequency you're using, the resistance remains the same. Resistance is frequency independent in a normal, healthy individual. That's an important statement. Okay. The reactance line, which is the green line, it starts from a negative value at 5 hertz. So at 5 hertz, it's a negative value. This reactance is called X. So the acronym for reactance is, the short form for reactance is X. At 5 hertz is called X5. As you increase the frequency, the line becomes and less negative, reaches the 0 point, and then it becomes a positive line. A negative line, 0, point of 0, and then a positive line. This is called as a line of reactance. Okay. This portion from 5 hertz to this portion where the reactance touches the 0 line, this 0 line is called as resonant frequency. So this red portion over here is the one that represents the capacitance, the negative portion of the reactance, the capacitance. And this triangular portion is called AX, or area of reactance. It's a very small triangle that is formed from the 5 hertz frequency up to the resonant frequency. This is called area of reactance. And then the portion above the resonant frequency, this is the inertance portion of the reactance. So this is the compliance portion of the reactance, negative portion, resonant frequency, and the positive portion is called as the inertance portion of the reactance. I hope you all have understood this. Now, essentially what it means is these are the parameters that we get based on these values over here. So you get resistance that is measured at 5 hertz. And as explained in my previous slide, I told you R5 represents total airway resistance, right? Deeper portions of the lung. Low frequency goes deep into the lung. So it measures your total airway resistance. The higher frequency, which is R20, travels only up to your large airways. So it measures resistance of your large airways. When you subtract R5 minus R20, you get resistance in the small airways. So for the resistance parameter, there are 3 important parameters: R5, R20, R5 minus R20. Then in the reactance line, there is one point over here which is 0. That portion is called resonant frequency. This resonant frequency is anywhere between 8 to 12 hertz. So you can see this 5 hertz to 20 hertz. So your resonant frequency usually in a healthy person lies between 8 to 12 hertz. Before that is your reactance. So that X5, this point over here at 5 hertz, the negative point is called X5. And this portion, as I said, the triangular portion from X5 to the resonant frequency is called area of reactance. Now, these are the important fundamental parameters that you require in oscillometry. However, I'll tell you that there are a few more evolving, which also give you more useful information about the function of your lung. X5 inspiratory and X5 expiratory. They tell you the reactance at 5 hertz during inspiration, reactance at 5 hertz during expiration. Okay, X5 inspiratory, X5 expiratory. So this is the reactance, but it has now removed the inspiratory component and removed the expiratory and the inspiratory component, gives you those 2 numbers. The delta between X5 inspiratory and expiratory is called as delta X5. So inspiratory minus expiratory is called delta X5. So these are the important parameters that I believe each one of you all should know as if you want to start interpreting. Now, this is the clinical application of each of these parameters. So what is Z? Z is that total impedance, total lung impedance, which is a combination of resistance and reactance. R5 is the resistance across the entire respiratory tract. R20 is resistance in the large airways. R5 minus R20 is resistance in the small airways. Then the reactance at 5 hertz, X5, what information does it provide you? It provides you information about small airways obstruction. It provides you information about lung elastance, about lung compliance, and about lung heterogeneity. What is lung heterogeneity? Lung heterogeneity, there are multiple small airways across the lung. Now, out of, say, there are 100 airways. So there are 30 that are blocked and 70 that are patent. So that 30-70 means that 1/3 of them are blocked, 1/3 of them are patent. That is called heterogeneity. If all the 100 are patent, then it is called ventilation homogeneity. But if some of them are blocked, that is called ventilation lung heterogeneity. So lung heterogeneity can also be picked up by X5. So this is the clinical application of X5. What does area of reactance tells you? It tells you what is happening in the distal portion of the lungs, both small airways as well as lung parenchyma. Very useful tool that tells you distal to the airways, what is happening inside the terminal portion of your lung. Resonant frequency gives you information about airflow obstruction and lung restriction. And I'll show you in my subsequent slides how we use this parameter to make a diagnosis. Very important. X5 inspiratory and X5 expiratory. If your X5 inspiratory is more than your X5 expiratory, what do you mean by more? X5 is anyway negative. But if it is more negative, X5 inspiratory is more negative than your X5 expiratory, then it tells you that there is restrictive lung disease. And exactly the opposite. If your X5 expiratory is more negative than your X5 inspiratory, then it tells you presence of obstructive airway disease. So I'm going to show you all this in the subsequent slides so that you will understand the value of each of these. Here is a very classical oscillogram that you see in asthma. Blue dotted line is the one that of a healthy normal individual, and the green dotted line is the reactance line. So blue is the resistance line, green is the reactance line. Now in asthma, see what has happened to the pre-bronchodilator, R5 value. This is 5 hertz, isn't it? So R5 is increased as compared to a normal healthy individual. It is increased. R20 is also increased as compared to that of a normal healthy individual. So R5 is your total respiratory resistance is increased. Your large airways, which is your R20, is also increased. So there is a mixture. Both large airways and small airways are obstructed. But if you see the R5 minus R20, R5 minus R20 is also increased. So everything is increased. Your small airways are obstructed. Your large airways are also obstructed. Now, when you give this patient a bronchodilator, 2 puffs of salbutamol, wait for 15 minutes, 20 minutes, repeat the oscillometry. See, the R5 value has come down. What has happened to the R20 value? It has come back to the normal range. R20 comes back to the normal range. And R5 minus R20 is still higher. So after giving a bronchodilator, large airways open up, but the small airways don't open up as much as the large airways. That's what it is telling us. The reactance line. This is the pre-bronchodilator reactance line, which means that compared to this dotted line, this green dotted line, which is normal healthy individual, X5 has become more negative. X5 has become more negative. This point of touching the 0 line, this is your resonant frequency. See, the resonant frequency of a normal healthy individual, this green dotted line is here, isn't it? So the resonant frequency has shifted to the right. And the area of reactance has become a very big triangle. After giving a bronchodilator, X5 has now become less negative. The resonant frequency, which was here, after giving a bronchodilator, has shifted over here, shifted to the left. And the area of reactance has also become smaller. So this is what you classically get in an asthma patient. What do you find in a COPD patient? Very interesting. Blue is the normal dotted line of a healthy individual. Green is reactance line. Resistance line, reactance line. Pre-bronchodilator. See what has happened to R5. Increase as compared to that of a normal healthy subject. See what has happened to R20. It is the same as that of a normal healthy individual. Why do you see that? Because COPD is a disease that primarily affects only the small airways. Large airways are not affected. In asthma, large airways are also affected. In COPD, your R20 value will be very close to normal. And therefore, your R5 minus R20 becomes a very big number, telling you that there is a lot of small airways obstruction. So this delta between R5 and R20 is a very important parameter that tells you small airways obstruction. After giving a bronchodilator, the R5 value becomes slightly reduced, but not as much as what we see in an asthmatic patient. Okay, so this is the post-bronchodilator. If you see the pre-bronchodilator reactance line, this is the one. X5 has become very, very, very negative compared to that of an asthmatic subject, become more negative. The resonant frequency, my God, is shifted too much to the right. And the area of reactance has become a very big triangle. After giving a bronchodilator, X5 has become less negative. Resonant frequency has shifted from here to here. And the area of reactance has also become a smaller triangle, sorry. So this is what you get in a patient with COPD. Now here is just to show you what we classically get in small airways obstruction. So this is the oscillogram of a normal healthy individual. These are the frequencies, 5, 10, 15, 20, 25, 30. Here is what we see in a small airways obstruction. R5 value goes up, R20 is normal. Therefore, your R5 minus R20 is big. X5 becomes more negative. Resonant frequency shifts to the right, and the area of reactance becomes very big. So these are all the parameters that tell you what is happening in small airways obstruction. Now, this small airways obstruction is much, much better picked up in oscillometry than in small airways obstruction. That's important to know. Now, so this is the normal value for resistance, the normal value for reactance. I've just shown you these shaded colors. So green is for normal resistance, blue is for normal reactance. And here are the resistance lines. The resistance line is a straight line. The reactance line is this blue line. At 10 hertz, it crosses the 0 line. So the resonant frequency is 10 hertz. This portion is called area of reactance. Compliance portion, inertance portion. Okay. Now, as your obstructive, so this line that you see here, it's a straight line, isn't it? R5 is also increased. R20 is also increased. But your R5 minus R20 is normal. So this is pure large airways obstruction. Pure large airways obstruction. Now, when you have small airways obstruction, pure small airways obstruction, R5 value is increased, but your R20 is normal. And your R5 minus R20 becomes increased. And then as your obstructive airway disease increases, so mild, moderate, severe, is how, as the R5 value keeps on going higher and higher as compared to your R20 value. And the same thing happens with the reactance value. So mild, moderate, and severe is the line keeps on becoming more and more negative. Your resonant frequency shifts to the right, and the area of reactance become bigger and bigger. So that's how you do that. Now, predicted values for oscillometry. Now, before that, we have to understand that predicted values are very crucial for spirometry. Why? Because spirometry values depend on gender, age, height, weight. So obviously, you have different values for males, females. You have different values for different ages. As you can see over here, from birth till about, say, this is 90 years old, your FEV1 or even your FBC values, they keep on increasing very sharply up to the age of 20. Okay, up to the age of 20, your lung volumes increase. At the age of 20, after the age of 20, they slowly start declining as you become old. So there is a big difference with age. So if you're, say, 10 years old, you're 15 years old, 20 years old, 30 years old, 40 years old, 50 years old, 80 years old, everything changes with age. And they change dramatically with age. So therefore, if you want to do your interpretation of spirometry, you have to have a predicted equation. Similarly, look at the ethnicity differences. In the age group up to 20, ethnicity doesn't make much difference. But after the age of 20, you can see that ethnicity has a big impact. Whether you're born in America or whether you're born in India, it depends. Your values keep on changing. So ethnicity makes a big difference. Height makes a big difference. As your height increases, your lung volumes increase. So together, age, gender, height, weight, they contribute to more than 70% to even 90% of the variability. And therefore, it is crucial to have a predicted value for spirometry. Right? Now, do we have a predicted value for oscillometry? So my PhD student, Nitin Manzara, he's become a PhD doctor now. He wanted to find the reference values for impulse oscillometry for the Indian population. And therefore, he spent 5 years in doing this study. 1,200 healthy individuals were recruited from the community. He went to the temples, he went to offices, he went to the railway station, he went to the parks, and randomly selected healthy individuals. For one healthy individual that he could recruit into the study, he had to screen 10 healthy individuals. So he put in a lot of hard work. He took the impulse oscillometry device, the 25 kilos it weighed. He took it with him to all the places and then measured their lung function in these 1,200 healthy individuals. He wanted to find the predicted equation for impulse oscillometry for the Indian population. Now, when he did the analysis, he was very, very depressed. So Z is the impedance, which is a combination of your resistance and reactance. Z at impedance at 5 hertz versus age. My God, doesn't change with age at all. What about resistance at 5 hertz? Oh, it's almost a flat line. Doesn't change with age. Very, very light, slightly. But what about reactance values with age? Well, almost a flat line. Almost a flat line. For height, there's some signal that we got with height. So as your height reduces, your impedance values also increase. So this is there's only one small thing that we found for height. So by and large, in spirometry, all those parameters, age, gender, height, weight, they contribute to 70 to 90% of the variability. But in oscillometry, they contribute to only 10 to 20% of the variability. And he said, sir, 5 years of hard work, and my predicted equation shows that all these parameters contribute to only 10 to 20% of the variability, which is very poor. There's very little contribution from age, gender, height, weight. And then, so we felt very sad. Both of us felt very sad. I said, did you dig out the literature? He said, yes, sir. Even others have found the same thing, whether it is done in Germany or done in the in other European countries or in Japan. Everybody has got more or less a flat line. Very little contribution from this. And then, suddenly, dimag ki batti, tuck karke, when it burns very bright, there was this realization that maybe we do not need predicted equations for oscillometry. Do we need a predicted equation for your blood pressure? Do we need a predicted equation for your blood sugar level? Do we have to feed in a formula for your age, gender, height, weight, for your normal blood sugar levels? No, we need single cutoff values. A single cutoff values is good enough to differentiate between normal and healthy. So we did some preliminary analysis of the data that we had, and lo and behold, we found exactly that. That for oscillometry, you do not need a predicted equation. You just need single cutoff values, one single cutoff value, just like what you require for blood pressure, just like what you require for blood sugar levels. So this was a very, very important realization that we had. We published this as a letter to the editor in the European Respiratory Journal Open Research this year. And I can tell you that this is going to be a huge benefit for doctors who are using oscillometry, because you don't need a predicted equation. You just need single cutoff values. Now, what I'm telling you over here is the cutoff values that we derived for adults using the Antler device, which is the Indian device. Based on, we did not even require more than 100 or 150 patients to do that. You're getting a very strong signal over here. And these are the cutoff values that we got. So click a picture of this, because this will tell you what the normal cutoff values are, at least that you can use in a clinical practice. Now, the values that I've mentioned here are in centimeters water per liter per second. There are some devices that give this unit, centimeters water per liter per second. The impulse oscillometry from the Jaeger one, it gives a different unit. It gives kilopascals per liter per second. Now you can convert the kilopascals per liter per second into centimeters of water by using a conversion factor of 10.197. So 1 centimeter water per liter per second is equal to 10.9 into kPa per liter per second, just multiplied by 10 times. Whatever the kPa value is multiplied by 10, you get it into centimeters of water. Now, these are the cutoff values. For R5, it's 4 centimeters water. For R20, it's 3. R5 minus R20 is 1. Now, these are the cutoff values. These are the, anything above this is abnormal. For X5, it's -1. So anything below -1 is abnormal. Anything above 4, area of reactance is abnormal. Resonant frequency, anything above 12 is abnormal. We also derived this, but now this is still in the development stage. Now, the key message over here is this is only for adults, not for children. I'll tell you why. Now, there is something that you must know before we go ahead. These are all the different devices that are available in the market. So you have the impulse oscillometry, we have the TremorFlow, then the MOST graph from Japan, the SMON Pro, and so on. So this is a paper that was published in 2019 that compared the values that you get from different devices for a low test load and for a high test load. Each line is a separate instrument, a separate machine, separate machine from different companies. So you can see that there is some variability over here. For low test loads, there is some variability for resistance. At high test loads, the variability becomes very high. So if you measure it with this device, this is the resistance that you will measure. If you measure it with this device, this is the resistance that you will measure. So there's a big difference between devices. So between devices, you get different values. Now that is important to know. If you look at reactance as well, so even at low test load, this machine, normal X1, X5 is this number, whereas this machine gives you -2, which is normal for that. So different devices give different cutoff values, and especially at high test load. So you have more airway obstruction, then the difference becomes even much more bigger over here. So what is the message from this study over here? Different devices provide different values. Very important to know. You can't compare a number that you get from iOS versus a number that you get from TremorFlow. You cannot, because they give you different numbers. Difference is higher with higher test loads, and the results of one device cannot be compared with the other device. Now, the application of this is each device must derive its own cutoff value. So the cutoff value that I have showed you here is for the Indian device called Antlia. We will have to develop the cutoff values for all other devices if you want to use it in clinical practice. But by and large, these cutoff values are fairly good enough from an application or an interpretation point of view. And then more important, we need to have harmonization or standardization for FOTs, like what we have for spirometry. So there is a whole standardization for spirometry. Now there is an ATS and ERS committee that is being formed to now look into this matter and then make sure that all the different devices that we have, they should all measure the same value. So how can we harmonize that? How can we standardize that? That process is happening as of now. Now for children, it's a different matter. So here is from birth to adolescence, and this is from adolescence onwards. So what I've shown you with age, R5 values do not change with age. X5 values do not change with age. But in the pediatric population, from 3 years to 15 years, the values keep on reducing with age. So this is the normal value for a 3-year-old child, normal value for a 5-year-old child, normal value for a 10-year-old child, normal value for a 15-year-old child. After 15, it's a straight line. So if you're doing oscillometry in children, then you do not use this straight line equation. There is no single cutoff value then. For children, you need an equation. Or you need to have different cutoff values for different age groups. And let me show you this over here. So this is a paper that is not yet published. So, but I managed to pull in all that information together. This is your age in years. This is your resistance value at 5 Hertz. Now this line is for 3 years. So what is the normal resistance at 5 Hertz for a 3-year-old child? 12.2. What is that for an adult? If you remember, normal R5 for an adult, 4 centimeters water per liter per second. For a 3-year-old child, it is 12.2. For a 5-year-old child, it is 10.1. For a 10-year-old child, it is 7.1. And for a 15-year-old child, it's 4.07. Then it becomes a straight line. So these are the cutoff values for different age groups in the pediatric population. The same thing for X5. So in younger age group, say in 3 years old, the X5 should be minus 5.09. What is the normal cutoff for X5 for an adult? Minus 1. In a child of 3 years old, it's minus 5. Minus 5 is normal for a 3-year-old child. For a 5-year-old child, it's minus 3.5. 10-year-old child is minus 2.4. And then for a 15-year-old child is minus 1, and it remains the same. Okay? Look at resonant frequency. In an adult, the normal resonant frequency is between 8 to 12. In children, for a 3-year-old child, it is about 30, up to 30. For a 5-year-old child, it's 22. For a 10-year-old child, it's 18. And for a 15-year-old child, it's 14. And then it becomes 8 to 12 after that. So that is the reason why if you're doing oscillometry in a child, you need to use higher frequencies from 5 hertz to 30 hertz. Why? Because the normal resonant frequency in a child of 3 years old is 30. So if your frequency is only from 5 to 20, you will not be able to measure the resonant frequency. Okay? So for a child, you require 5 to 30 hertz. For an adult, 5 to 20 hertz is enough. Now let us do some examples. Let's see how accustomed you are to this. So these are the cutoff values. These are the measured values, and I've just put the percentage change over here. So R5 value is increased. R20 value is also increased. But your R5 minus R20 is normal. So is there obstruction in the airway? And if so, where is it? Is it in the large airways? Is it in the small airways? Or is it everywhere? Tell me the answer. So here, very good. This is typical large airways obstruction. Pure large airways obstruction. Another example. R5 is increased. R20 is normal. R5 minus R20 is increased. So where is the obstruction? Is there obstruction?
Yeah.
And if so, where is the obstruction?
Small airways.
Large airways, small airways.
Pure small airways obstruction. And the final one. R5 is increased. R20 is increased. R5 minus R20 is also increased. So both. So large and small airways obstruction. So in interpreting R values is very simple. If you have understood the fundamental principles, then interpreting this is very, very simple. Let me showcase this oscillometry report of a 3-year-old boy. This 3-year-old boy had very classical symptoms suggestive of asthma, had 3 hospitalizations, presumably for asthma exacerbations during the last 1 year. But the parents were refusing to accept a diagnosis of asthma. They said, my child cannot have asthma. Both of them were they were all engineers, software engineers. And they said, doctor, can you give me proof that my child has asthma? I can't believe that our child has asthma. So the boy was referred to us. We did the oscillometry. And here is the resistance value. Here is the reactance value. The blue is the pre-bronchodilator. Red is the post-bronchodilator. Reactance value over here, pre is the blue and post is the red. Now, these are the graphs that tell you the resistance at 5 hertz was, now look at here. This is kPa per liter per second.
15.
So this is when you want it in centimeters water, you multiply by 10.197. So this is about 15, correct? This is 1.4, 1.5. 1.5 into 10 is 15. So here it is, 15.4 pre-bronchodilator. After giving a bronchodilator, it came down to 8.7. Look at the change. Look at the R20 value. Pre-bronchodilator, post-bronchodilator. 8.9 became 5.0. I've just converted from kPa to centimeters water per liter per second. Look at R5 minus R20, 6.5. Pre-bronchodilator, 3.7. Post-bronchodilator. Look at the X5. X5 has become less than 0.8, isn't it? Less than minus 8, minus 8.15. Now, if I show you the graph of the child, I think for a 3-year-old child, the normal R5 is 12, right? R5 is 12. And the normal X5 is minus 5. So both the values have become, R5 has increased, X5 has become more negative. And after giving a bronchodilator, look at that wonderful change that has been found. 3-year-old guy. So now the parents are convinced that my child has asthma and they've started the child on asthma treatment. after seeing this report. That is the value of oscillometry. Now, here is another example, 48-year-old female professional singer, cough at night time that keeps her awake, shortness of breath, no family history of asthma. Spirometry was done, FE1, FVC. You can see the bronchodilator response plus 7% and 120 ml. Doesn't fit into the criteria of good bronchodilator reversibility. And is there obstructive airway disease? Well, not very convincing. When we did oscillometry, look at this. So this is resistance and this is reactance. What is the resistance over here? Pre-bronchodilator 9.6. What is the value for a normal healthy person? 4. After giving a bronchodilator, it came down to 5.9. It came down to 5.9. And then similarly, R20, you can see over here. R20 from 6.3, 4.0. R5 minus R20, which is small airways. Normal should be less than 1. Here it is 3.8. Similarly, you can see X5 has become more negative pre-bronchodilator. After giving a bronchodilator, it has become less negative. Area of reactance, which should be 4, starting with, it has become 41. 10 times it has increased. After giving a bronchodilator, it has reduced to 13. So for a good bronchodilator reversibility, I think the best parameter that I use is AX, area of reactance. If the area of reactance reduces by 50% or more, that is good bronchodilator responsiveness from me. Or you can use R5, 40% change. So pre-bronchodilator to post-bronchodilator, 40% drop is indicative of a good bronchodilator reversibility. Now, here are 2 cases that I just wanted to highlight. See, here I put the cutoff values. Here I put the measured values in centimeters water per liter per second. Now, this is the pre-bronchodilator, post-bronchodilator, pre-bronchodilator, and post-bronchodilator. This is an adult. So obviously, R5 has increased. R20 is, well, not as much as increase as what R5 is. R5 minus R20 is huge. X5 is become really more negative, more than 5 times. Area of reactance, my God, look at the size of this, huge. And the resonant frequency has shifted to the right. After giving a bronchodilator, there doesn't seem to be much of some improvement in R5, but by and large, small improvement. On the other hand, over here, you can see that R5 is slightly increased. If this is the cutoff value, it's close to 5. So it is slightly increased. R20 is also slightly increased. R5 minus R20 is perfectly normal. X5 is become little more negative. Area of reactance is big. Resonant frequency has increased. Now, if you could tell me what are these 2 conditions, and I'll explain to you a little more of one additional parameter which I think is very important. And that is this one, X5 inspiratory and X5 expiratory. So here you can see the X5 expiratory is more negative than the X5 inspiratory. With this kind of a graphs, I am convinced that this is COPD. Okay? So this is obstructive airway disease, small airways, and expiratory is more negative than inspiratory. So this is clear obstructive. Now see here, X5 inspiratory is more negative than X5 expiratory. And all these values are slightly increased. R5 is slightly increased, X5 is slightly become more negative. Borderlines, or slightly borderlines. But this is more important. X5 inspiratory is more negative than X5 expiratory. So what does this tell you?
Be restrictive.
Interstitial.
How much is A?
So you can differentiate between COPD, obstructive airway disease, and restrictive lung disease by looking at this one parameter called X5 inspiratory and X5 expiratory. Now, here is another very good example of oscillometry in interstitial lung, idiopathic pulmonary fibrosis. So there is something called as intra-breath oscillometry. Let me come to this a little later. But here is a healthy individual, resistance line, reactance line. You can see the resonant frequency is over here, small area of reactance. This is normal healthy individual. And this is the oscillogram of this patient who has got interstitial lung disease. So you can see that the R5 is slightly, not much different. X5 has become more negative. Resonant frequency has shifted to the right. Area of reactance has become big. And you can see that the pulmonary vessel volume, which is an HRCT parameter, that gives you different color codes for these different observations. And when you correlate with that, the best correlation that you see is with AX. AX and resonant frequency show you the best correlation with this. But what is really interesting, there's one more test called as intra-breath oscillometry. And here we use only one frequency of 10 Hertz. At 10 Hertz, you do inspiratory, expiratory, and then you have X5 at end expiratory. XEE is X value at end expiration, X value at end inspiration. In a normal healthy individual, it's a straight line. There's no difference between X5 end inspiratory, X5 end expiratory. No difference. But in patients with ILD, look at this. X5 end inspiratory becomes more negative than X5 end expiratory. So I think very exciting times that oscillometry can help you in arriving at a diagnosis of interstitial lung disease. A very interesting case over here. Post-TB lung disease. Healed. Declared as cured. Pre-bronchodilator, post-bronchodilator. Pre-bronchodilator, post-bronchodilator. Can anybody tell me what does this look like now?
COPD.
COPD.
Post-TB COPD. Very, very classic. Very, very classic. Now, lung transplant is growing in India very rapidly. And the only test that is used to detect presence of bronchiolitis obliterans is ask the patient to do spirometry at home every day. And if below a certain level, if the FEV1 falls below that certain level, this patient is asked to report to the hospital immediately, and then high doses of methylprednisolone are given to treat that bronchiolitis obliterans. However, there's one interesting observation that has been made. Chronic lung allograft dysfunction, there are two types now. One is bronchiolitis obliterans, which is obliterative bronchiolitis of the small airways. Survival is 3 to 5 years after a lung transplant. But there is something called restrictive allograft syndrome as well, post-lung transplant. Here the survival is only between 6 to 18 months. Now, very difficult to pick this up on spirometry, no question about it. I mean, you cannot differentiate between these two, whether my patient has got BOS or whether my patient has got RS, post-lung transplant. You need to do something better than spirometry. And then there's a very old paper, this is 13 years ago, which showed, so here is the diagnosis that was made. There are the symptoms that, development of symptoms over here. So before the symptoms developed, oscillometry parameters showed a big dip over here. So this is your, this is your R5. This is your, R5 minus R20. And this is your X5. So the X5 becomes more negative. R5 minus R20 increases. And then your R5 suddenly increases before the symptoms arrive. This is when the time when the patient starts complaining of symptoms. After giving the treatment, everything comes back to normal. So your R5 comes back to normal, R5 minus R20 comes back to normal, X5 value comes back to normal. So this was a study done 13 years ago to show that oscillometry can pick up rejection much earlier than what symptoms do and much earlier than what spirometry can. And this is a very recent, 2 years ago, this is a very nice paper that was published. Bottom line, oscillometry can pick up lung rejection earlier than what spirometry can. And this is a paper that was just published end of last year, where you could differentiate between BOS and RAS using spectral oscillometry. So you get a very classical type of in obliterative bronchiolitis, your end expiratory becomes more negative, and in restrictive, your end inspiratory becomes more negative. So very classical shapes that you can get in a patient post-lung transplant while doing normal tidal volume. So that's the beautiful application of this. Last couple of slides. I like this article by Professor Peter Calverley, one of the big names in the field of COPD. And what he's written is, just read the title yourself. Why has oscillometry remained a neglected entity? For various reasons. But if you see the number of publications arising, they're growing logarithmically over the last few years. Technical standards for oscillometry, very, very good paper in ERJ 2020. Please get this paper. You will get everything that you want to know about oscillometry. And then the clinical significance and applications of oscillometry. published last February in the European Respiratory Review. It's a very, very good review that tells you about the application of oscillometry in clinical practice. 2 slides before I leave, we have set up a network called as the ARISE network, which is the International Network for Lung Oscillometry Research at our institute in Pune, which is perhaps the largest network for lung oscillometry anywhere in the world. We have more than 30 members who have become members of this network. And over the last 1 year, we have collected data of close to 10,000 patients of asthma, of COPD, of interstitial lung disease, and so on. So I would like to invite those who have an oscillometry device to become a member of this network, because together we can, we can amplify the research that can be done in this field. So Disha Ghorpade, who is the lead for the ARISE network, this is her email address over here. So if you're interested, you can send her an email. And then we have started this Omega training program, which is an oscillometry training program for lung disease. We started this last year. Last year, we conducted some 8 programs. This year, we're planning to conduct 16 programs across the country. So look out for this Omega program. It's a 4-hour program, little more in-depth knowledge than what I have done today. It will tell you everything about how to perform, how to interpret, and so on. So if you're interested, keep your watch out for the Omega program. I'm going to stop over here, and just before I end, I would like to suggest that lung oscillometry is predicted to become the future of lung function testing. So those of you all who have an oscillometry, well, I think you should start using it. Those of you all who do not have an oscillometer, you must think of getting one, because this is going to be the future of lung function testing. So I'm going to stop over here, Dr. Amita, and I'm sorry if I've gone a little ahead of time. My God, it's already 9:30. I'm so sorry.
Thank you so much, Dr. Salvi. It was really very, very enlightening. And my God, all the physiology that we'd forgotten, you've got us back to it. So with this, I'd like to start the panel discussion. A quick introduction to my very, very esteemed bright panel. Honestly, each of them are great achievers. None of them really require any kind of introduction, but just for formality, we have Dr. Suhas Bardapurkar, a senior pulmonologist from Aurangabad, and his area of interest is obstructive airway disease. And I believe he's the first one to have iOS, and he's done so much of work in iOS in Aurangabad. So, dear friend also, welcome Dr. Bardapurkar. We have Dr. Nitin Abhyankar, again, doesn't need any introduction, my dear friend, interventional pulmonologist, a great human being, a consultant at Pune Hospital. Then we have Dr. Salil Bendre, who I've studied with. We are classmates. He knows me more than any of you all know me. All my secrets are known with him, and I know all the secrets. But a fantastic human being, a multitasker, really a house of talent. He's a HOD at Nanavati, a great teacher and a dear friend. And last but not the least, a very, very bright and actually brilliant Dr. Lakshmikant Yenge, the only DM under us. He is really very, very bright. He likes to go into all the details of everything. And so I'm sure this discussion is going to be very, very interesting. There are so many questions which have come up also. So before that, just a quick revision what has been told. We start with Dr. Lakshmikant. So Dr. Salvi has already told us, but I still want to ask you again, what is the difference between iOS and FOT, and which is more reliable and why?
Yeah, I think we are already very late, so I'll not take a lot of time. I'll be very, very quick. Dr. Salvi has already told about the differences and the family or the nomenclature or the revised nomenclature we can go through. Actually, there is no real difference which one to choose over the other. The only other difference which has been missed and has not been exemplified so far, and which may not be of very clinical significance, is that the impulse oscillometry device uses the sinusoidal wave pattern of the sound waves. The FOT device one. And this uses the square wave pattern. Impulse oscillometry uses the square wave pattern. But as has been already discussed about the 10 different devices which have been compared in the trials also, there is some variability, but not really a difference. And the value should be taken for each device and not try to correlate value of one device with the other one.
Correct.
That's
Yes,
all.
the thing is we need to know the value of each device that we take.
Yeah.
Coming to Dr. Bardapurkar, who's done so much work on iOS. So I just want to ask you that if I want to buy an oscillometry device, so it's a little confusing. Should I go for iOS? Should I go for FOT? What is the difference of the cost and what is the advantage, disadvantage of each?
As Dr. Lakshmikant Enge has rightly said, both are equally effective. In FOT, particularly, we send the wave of 5, 10, 40, and 20 like that. And in iOS, all these waves are mixed up and they are sent to the patient's tidal volume. And in my opinion, the iOS was found to be far comfortable. However, FOT is also comfortable if we compare it with spirometry, but both are same. And the machine which I am using is TremoFlow, that is made in Canada, and that cost about 10 lakhs. And I'm also using FOT by the company in Bangalore. We are sending these reports to Dr. Salvi, that is Antilia.
Okay, great. So if anybody wants to buy something, would you recommend FOT or iOS?
In particularly Antilia FOT, we don't get AX. Dr. Sandeep Salvi will agree with me. In this iOS by TremoFlow, we get excellent AX. And of all, AX is very important pattern which we look at because, for example, even in asthma, if asthma is not well controlled, many times spirometry may be normal, but AX is quite large. That is Goldman's strangle. And if it is large, then there are chances that he or she can get exacerbation. And we have to intensively treat this to reduce his AX.
Correct.
So,
Just one more point, sir. Do we get a spirometer along with the other devices which we have? Because the Jaeger impulse oscillometer gives spirometer along with. So you don't have to buy the two different devices. You may go away with only one device which can give you both spirometry as well as impulse oscillometry. And in fact, even you can customize the report in a single page where you get the report of impulse oscillometry as well as spirometry simultaneously. So that is the advantage with the Jaeger one or Wire one, which is the latest company name. I'm not sure whether the other devices have the same facility, whether they provide the spirometry parameters also.
For example, Antilia is only FOT and TremoFlow is only RS or air, to be very specific, air oscillometry.
Okay, fine. Thank you. Coming to Dr. Salil. So, Salil, what are the advantages of oscillometry over spirometry? Why has it become such a hot topic these days?
So, first of all, thanks, Dr. Salvi sir, for that wonderful description and making it much easier for all of us to understand, because this is a very new concept and all of us are in the learning phase. So, thank you for that. And Amita, coming to your question. So, obviously, if we put it in the real-time scenario, if we have a child, a 4-year-old, 5-year-old child, and we want to evaluate the airways, I think definitely oscillometry is going to score over a spirometry. Same holds true for an adult patient, elderly patient who is unable to perform a spirometry, which we know maybe 30% of them may not be able to perform that spirometry, or they are performing, but they are not performing it the way that it should be done. So the outcome may not be the correct report. So in many such situations, oscillometry is going to be the test of choice, because as we have seen, it is based on the tidal breathing. The simplicity is the key where oscillometry scores over a spirometry. And trust me on that, once a patient does an oscillometry, the next time you offer him anytime a spirometry, he's going to say, Doc, I want to do that test only. I don't want to come back to do a spirometry. So it's that simple.
Correct. So when we have children or we have old patients or people who don't really understand, I think it would be always better. Right. Dr. Vardapur wants to say something?
I would just like to add two conditions in which we cannot do spirometry or the spirometry is contraindicated. That is, the repeated pneumothorax, and the myocardial infarction. PFT, we can do it after 6 weeks, but impulse, we can do it within 7 days of period. So these are two indications. And also in third trimester of pregnancy, usually nothing happens with spirometry. However, patients are afraid, and that's why it is very easy to subject the patient for IOS.
Correct. Actually, when aneurysm anywhere in the body, so spirometry is completely contraindicated. So I think a patient of aneurysm, IOS, we can definitely do oscillometry for these patients because it's tidal volume. So I feel oscillometry is really the way forward. And I think anybody who doesn't have it should try to procure it. And I'm sure more and more data is going to come out. Coming to Dr. Salvi again, you explained us so much in detail. But I still want to know cutoff values, because a report that we get in our hospital, we get values and then we get percentages. So if we look at the percentages, can you tell us, for R5, R20, R5 minus R20, AX, what are the percentages that we look at?
So earlier when we started doing oscillometry, before we did this study that we just published, we used to use the percentage change. If your R5 value goes more than 50% of the predicted value, you say that this is increased R5. That is the only parameter. So for X5 also very similar, more than 40% reduction in X5, you would say that fits into the criteria of more negative X5. But having started using fixed cutoff values, I think that is the way to go forward. We should, even whether it is iOS or whether it is the tremor flow, if you use the cutoff values that I mentioned, I think they give you all the requisite information to make a proper, reasonably good quality interpretation. Use those numbers, and I think that is better than doing percentage predicted or percentage.
Honestly, even the way I used to look at the report was that, if R5 was more than 120 or 125%, I want to call it increased airway resistance. So the thing is that, so you suggest we only look at the values.
If your R5 is more than 4 centimeters water per liter per second, it's high.
So R5 is 4, R20 is 3.
Or 0.4.
Or 0.4.
Or 0.4 if you are using the iOS machine by Eager.
Using KP, yeah.
Okay.
0.4 and 1 is something which we can remember.
So
0.4 and 0.1.
Which value where?
Sorry, but doesn't that become very arbitrary that, anything more than 4, 4.1, it is obstruction, and 3.9 becomes normal?
So you're right, Dr. Abhyankar. So we will have to have some gray area to say if the symptoms and the gray area match, then maybe you should consider obstructive airway disease. But if it is more than 4, then I think for all practical purposes, it should be obstructive airway disease. We'll have to have those zones as well. That will happen with time.
Correct. So now coming to Dr. Nitin, he's led me into a very interesting question. So Nitin, how do you diagnose obstructive airway disease? Because this 4 and 4.1 and 3.9 will happen. So how do you diagnose? Yeah.
So I think I absolutely definitely use the clinical story in first, and then do whatever else I'm doing, because I think there is going to be two ends of spectrum. As I think I'll open a can of worms right away if I say that there's going to be a false negative and there are going to be some false positives. So one way or the other, even in a hypersensitivity pneumonia, I'm going to get some because it is a bronchocentric kind of a thing. And there are papers in that territory also. So there'll be certain number of cutoffs. So I think we are right now not in a complete control on this situation like what we are in spirometry. Spirometry tells you 12% plus 200 and more as an absolute cutoff point, which is acceptable as a worldwide truth. Of course, that also is debatable, but at the same time, I think there must be some kind of a cutoff, and that some kind of a cutoff needs to be generated. It will be over a period of time that we will have it, and I think we'll have to make efforts towards it. So a true, genuine, definable asthma, of course, in the right clinical settings, but non-refutable. Say a clinical trial should accept it. So he has to get enrolled into a clinical trial. It should be acceptable. And I don't think we have those kind of cutoffs at this point in time. So how I go about, it's a very simple way, which Sandeep sir tells us. And I think I'm very, very close to that I'll first look at the R5. look at whether it is increased. For me, my machine is iOS YR, so they have given that anything more than 20 to 25% more than the normal is considered to be abnormal. So if it is R5 is 125% and above, and if it is particularly above 140%, I'm 100% sure on that. And the other thing which I look at is AX. Again, the AX change, if it is more than 40%, then I take it as an abnormal value. And often in asthma, you tend to get both. But of course, not necessarily, because asthma can be a largely large airway disease to begin with, and over a period of time, the smaller airways could be involved. In COPD, it is much more easier because both are reflected in a considerably abnormal way. I unfortunately haven't worked with the inspiratory versus expiratory X5, which Sandeep sir has just taught us. So I think that is going to be my new target, which we will eventually explore. So I think these 2 or 3 ways by which we start interpreting. Of course, I think we keep adding more values, it will become more accurate. It might become a little more confusing also on the other end. But I think the crux of the matter is, again, that R5 minus R20, it's a bare bug. It's not necessarily reflected in all asthmatics. It's not even necessarily reflected in all COPDs that I'm seeing. So those COPDs considered to be a completely peripheral disease, I still seem to be getting a not so strong R5 minus R20 signal, and vice versa, that even in an asthmatic where we say small airways is dominant in some of these patients, I get 70-80% R5 minus R20, and even that seems to happen. So I think in clinical practice, once any investigative tool is put into practice, you get all kind of funny things, and therefore at this point in time, I would hesitate in sort of putting an absolute number to anything, but the clinical sense of it combined with a reasonable certainty. The change has to be at least 20-25% in R5, and the change should be at least 40% in AX. That's what I'm looking at.
Yeah, I think yes.
I just had one comment, ma'am. See, the classification of small airway disease, which is given or conventionally considered for small airways versus the R5 minus R20 is representative of the areas or the airways is slightly different. Beyond the 7th or 8th generation, which includes actually the muscular airways also, is included in the R5 minus R20. And when we say the small airway disease, we are primarily saying the airways which are less than 2 millimeters. So there is a lot of overlap there, and this is the difference which actually is responsible for the difference which we are getting, or we are perceiving, we are trying to look for, but we are not getting. This is because of this difference.
Yeah, and most of our asthmatics who come to us have, for say, about 15 to 20 years of missed opportunity of getting inhaled corticosteroids. So they have substantial amount of airway remodeling, and that creates, from the so-called early large airway disease to a very, very COPD-like scenario. And I would love to call it COPD, AOPD, but I think the latest GINA guidelines call it COPD-A. So I think whatever that.
Okay, so no, but point very well taken. Actually, the thing is that I went through like a lot of presentations last night on iOS because I kind of felt that even I had to know everything that was available. So ERS has actually given an excellent deck of slides which is available on the net. And as per ERS, they are saying that if R5 is 120 to 125%. Yeah. Then you should call it obstructive airway disease. Dr. Salvi has taught new stuff today because I was never really looking at absolute values. So I've really learned. And I kind of feel that a very important point also well taken by Dr. Salvi, that when we buy an instrument, in fact, our hospital, they have given us all the parameters. What values to be taken as normal, which we used to not really look at. So I think we must go through the literature given by them because, as Dr. Salvi said, that every device has their own data. And I think we will have to report our IOSs based on the numbers that the instrument is given. So I think that's really a great thing. Coming to Dr. Salil. So Dr. Salil, now we know large airway obstruction, R5, 120 to 125% and more, or more than 4, or multiply by 10 to make it into KPA and 40. So what about small airway obstruction? How we diagnose small airway obstruction?
So all these talks, and we have already, I think, discussed this, that R5 minus R20. I mean, when you see the oscillogram by the curvature also we can make out, and very beautifully shown by those examples and the percentages which Dr. Salvi sir in the last 5-6 slides, which he mentioned about the way the improvement of the initial upper at R5, the resistance is high and then it moves down and comes to the normal. So from the oscillogram itself, we can actually make out that this is going to be a small airway obstruction. And by the cutoff, as sir has mentioned, so the R5 minus R20 is what we are looking at, because R5 we know talks about throughout the airways and R20 is the proximal or the larger one. So we subtract these two and we get the smaller airways.
Right. So again, the machines, in fact, are, they actually give it R5 minus R20 more than so much small airway obstruction. So yes, sure, sir.
I would like to ask Dr. Savi one question regarding small airways. The cutoff value is 1. Okay, that also we are always considering without remote flow. Now, in a patient, if his R5 minus R20 is 0.8 before bronchodilator and that becomes 0.04 after bronchodilator, means there is 50% improvement. What do you call this?
Very good point. It's a good point. I don't think I have a good answer for that. But the cutoff value that I suggested, which was 1 in terms of centimeters water per liter per second, there are some papers who have suggested that you can even go up to 0.8 centimeters water per liter per second. Some have even gone to 0.7. So
our machine gives 0.7 for small airway. R5 minus R20.
So I think that debate is still happening. And until we generate our own data to get good quality cutoff values. So 1 is a little higher end, but starting from 0.7 onwards also, I think, gives a reasonably good indication of small airways. But I think Dr. Suhas Bardapurkar made a very good point. If it's 0.5 and becomes 0.2, that's more than a 50% improvement.
Absolutely.
Does it have any significance? I don't know the answer. We should do the studies to find the answers.
And in Eclipse study, which is, I think, done by Dr. KDA and Associates, they have given the cutoff values. The cutoff values are very simple and very easy to remember. R5 is 5. R5 minus 20 is 2 points. The small airway is 1. R5 minus R20 is 1. And then R20 is 2.6. AX 10. These are and of course, the resonant frequency, as you rightly said, 8 to 12, between 8 to 12. So that found to be very good. Even when I'm interpreting my IS reports, I found this test to be, these cutoff values to be very good.
So R5 is 5, R20 is 2.6, R5 minus R20 is 1, AX is 40.
10.
Sorry, 10. Okay, great. I think this is easy. Multiples of 2.5 almost. Coming to Dr. Lakshmikant.
This is from Eclipse study, which is the biggest prospective study in COPD patient.
Correct. Great. No, this is great. Coming to Dr. Lakshmikant, again, taking cue from what is asked by Dr. Bardapurkar, how do we classify what is good bronchodilator reversibility, what is poor bronchodilator reversibility based on the iOS report?
Okay.
You go.
So again, similar. We don't have clear cutoff, and the cutoffs are different for different values. For example, the cutoff for R5 minus R20, that is for small airways, is ranging somewhere from 20-25% to 50%. And for the large airway, it is somewhere around 30 to 40. And for AX, it is varying from 40 to 80. So in one paper, I read the 80, I read 40. So the values are very different. So largely, again, going back to the Dr. Salvi's, the first lecture I had when I was introduced to iOS, he said that anything beyond 30%, you can roughly consider it to be abnormal or significant at the moment. So 30%, 130% or 70%, less than 70% is on lower side is abnormal, more than 130 on the upper side is abnormal, and any change of more than 30 to 40% you can consider significant. Higher the change, greater is the confidence. Lesser the change, lesser is the confidence. And if it is not meeting these criteria, and if you still clinically your suspicion is very strong, which means the pretest probability is very high of having that particular condition, you can still treat like we do for normal spirometry.
So
I have one small point to add. Perfectly agreed with all the range of percentages, but the coherence values have to be 0.8 for R5 and 0.9 for R20. So the coherence has to be very good, because though it is a very simple test, people still mess the test up and they come up with a 0.5 or a 0.6, and that cannot be taken as a gospel truth. So I think that coherence values it's something like reproducibility criteria. So if the coherence is 0.8 for R5 and 0.9 for R20, then only these tests become acceptable, and because they are reproducible, and I think then they are interpretable. So I think that's important to underline.
Point very well taken.
Yeah, there is inherent interpretation software, sir, SentrySuit software by Wire, which gives whether the reports are acceptable or not. As long as it is very simple to instruct the clinicians that unless it is green zone, it is not to be stopped.
Unless it is green, don't take it. Simple. Agreed.
Yeah.
So just to sum it up for bronchodilator reversibility, we're going to look at R5, and we want the drop to be by about 30 to 40%. Is that correct? What about looking at the other value? What about looking at AX for bronchodilator reversibility?
40%. 40% drop.
Yes. So R5 30 to 40% and AX drop of 40%. Either of the two could be taken as good bronchodilator reversibility. This is for everybody to know. So now, Dr. Nitin, coming to you, how do you diagnose air trapping on iOS?
I seem to be maybe overdoing it, because that elastic recoil and the other issues also are playing a trick there. So if you take a severe restriction, also the AX is going to be a bit dodgy. But if you take a clear-cut case of a pure obstructive airway disease for 30 years, 40 years, and I see a AX which is 13, 14, 15, or as high as that, then I know there is going to be substantial air trapping. And whenever we have done about 100 cases where we have done our RVTLC and iOS together, and we have found that whenever there is the residual volume is more than, say, 200%, and the AX is usually more than 10 in the iOS kind of environment. So it will be 100 in the in Sandeep sir's machines, Antilia or other.
AX more than 10, can we take it as air trapping?
Almost severe air trapping. Whereas generally it is 1. Generally it is 1 in iOS, approximately close to 1 in iOS as normal. Anything above 1 is considered abnormal. But then, the severity goes up. If it is something more than 10, then you are really looking at a severe air trapping. Usually correlates very well with the residual volume and the TLC equations. And it's usually RV is more than 200% predicted.
Yeah,
it does correlate.
Sorry for the confusion. Yeah, okay. No, so
it does correlate very well, but I think it is better we avoid using the terminology air trapping. Here, because the exactly similar changes can be seen in exactly opposite disease where we are not going to get air trapping. So if it is clinically appropriate setting, it may suggest air trapping, but it is better we avoid, because air trapping is a terminology, or expiratory flow limitation is a terminology which is better demonstrated on either RVTLC or FVC. If at all we want to use the terminology of expiratory flow limitation or air trapping, I think it is better we use that X5 inspiratory minus X5 expiratory and see the difference. If that difference is significant, which is favoring the COPD, we can possibly try and use the terminology air trapping in that subset and not going only by the area of reactance.
Yeah,
So
because
does that
it's
mean that we
small
should
airways and elastic recoil of the lung and the peripheries of the lung. So even in a hypersensitivity pneumonia, you can get a so-called air trapping.
High access.
So I think
so the bottom line is the way I understand. Yes, Dr. Vardapurkar, you want to add something?
Look at what we look at spirometry is flow volume loop and graph, spirograph. Similarly, in airway trapping or COPD, look at the negative component. Right from X5, you go on tracing to resonant frequency. If it is 18, 19, then Goldman triangle is going to be quite big, huge. And in that case, it is severe COPD. And in COPD, usually we get air trapping. After, say, about 6 months of treatment, the Goldman triangle becomes less. It suggests that definitely there was airway trapping, which has been relieved with our treatment.
But in the right clinical setting, you can't just use it as a standard of care everywhere. Absolutely.
Right, so I think the bottom line is that we should not be routinely diagnosing air trapping based on the impulse oscillometry or oscillometry, because I think it's a point well taken, because we would like to think that this is applicable, but that is more of clinical application. The test is not really telling us. I think we should avoid doing that, I feel. Okay, coming to Dr. Vardapurkar. So, spirometry, we look at the loop, and often we come to know this upper airway obstruction because the inspiratory loop is flattened, or expiratory loop is flattened, or we get a box loop. So basically on oscillometry, can we diagnose upper airway obstruction?
Yes, you look at R20.
Okay.
But other parameters will be normal. Look at R20. R20 increases, and that is this even specific thing with upper airway obstruction.
But that would be large airway. I'm talking about upper airway.
Yeah, upper airway, you will get a line. So you will get a line which is raised from baseline. R5 and R20 both are parallel to each other. So you'll get that kind of a line, and box type of obstruction, what we are referring to. So, in that case,
both are elevated. R5 and R20 both are elevated.
Both are elevated, and they're equally elevated. So you'll get a line which is parallel to the predicted line. Above. And it will not be a curved line which is going up at R5.
That is if we have fixed obstruction. What if we have variable extrathoracic or variable intrathoracic obstruction? Can we diagnose? We can't diagnose.
No. You should not try to do that.
So there is PFT, which, in certain areas, we definitely need it. We can't just keep on saying it'll be replaced. So now coming to Dr. Salvi. So what is the role of iOS in restrictive diseases? You told us, but even today, can we diagnose restriction based on iOS?
So, I mean, this observation that your X5 end inspiratory is more negative than your X5 end expiratory is a very useful observation that has been made about 10 years ago. But more recently, I'm seeing a lot of papers that are being published in this field. So I believe that by looking at X5 inspiratory and X5 expiratory, you will get a reasonably good signal to suggest that you're getting a restrictive type of a pattern. Now, whether that is as good as maybe what you're doing your DLCO or your HRCT, time will tell. But I think the signal seems to be quite significant. So we need to do those studies, Amita. Perhaps if you have any postgraduate student who would like to do this, it would be a fantastic study because nobody has done that.
But sir, think of it. This is a brilliant screening tool for, say, in a factory where people are exposed to, say, pneumoconiasis or something like that, and a restrictive. And if this is used as a tool in a big way, I think it can pick up the disease much earlier, just like what you showed with the lung transplant rejections. So I think that early pickup is going to be very, very important and so easy to perform. Very importantly. So I think it can become the tool for future for that early restriction also. Though today we say, okay, that it is best reflected only in the severe restrictive disease. But I think in future we can make this,
There are so many questions from the audience. So I think let's just keep Dr. Vardapurkar add, and then I'll go ahead with the question.
What Nitin was saying, now I would like to tell you, to Dr. Nitin, in 3-4 years, 3D impulse oscillometry is going to come to India. It is now used in Japan, and they are using different color codes for inspiratory air and expiratory air. So that will be very easy to find out whether there is air trapping or not.
I think.
Okay, great. So I'm asking Dr. Bardapurkar that whenever you see an iOS report, you please tell us how you go about interpreting. What do you look at first? Then what do you see? What do you see? And after he finishes, I'll request the other panelists to add on if they do anything more. So if we have a report, how do we go about it?
Okay. Look at the graph, particularly the positive line, which indicate R5 total resistance, whether it is increased more than 5. Then look at R20 large airway resistance, which is, it has gone more than say 2.6. And then R5 minus R20, is it more than 1? Okay, this is one thing. And then look at downgoing line, that is X5. And X5, then look at the Goldman triangle. Is it more than 10? And look at the particularly resonant frequency, whether it is beyond 13, 14, 15. Normally, it has to be between 8 to 12. But if it is 15, then give bronchodilation. After bronchodilation, if I look at again all these parameters, if large airways do not have good reversibility, but small airways have good reversibility, and then even the AX become from, for example, it is 30, it becomes 20. So good small airway disease with the lung empty is better. So this is likely to be a case of COPD. And I would like to look at the coherence, which is not given anywhere in the graph or lines. It is given in the printout. The coherence has to be more than 7. Then that is accepted graph. Because as in spirometry, we know that this flow volume should be very, very smooth. There should not be any ups and downs in expiratory phase. Similarly, if patient is not properly bracing the cheek, or he has slight cough and many other conditions, he is more breathless because of anxiety. So coherence will go down less than 7. So coherence has to be more than 7 all the time, and look for the bronchodilator reversibility test. If the small airway improves by 40% and even the AX improves by 40%. I will say that this is, though, a case of COPD, which is good reversible COPD. And at times I do get bad reversible COPDs. These are the only two conditions where we can have a different phenotype, reversible COPD and irreversible COPD. That is also a question with me.
Okay, excellent. So the thing is that even for small airway, reversibility, we can look at R5 minus R20 also. And
Yes.
the drop will be 40%.
Right.
Right. Okay, fine. So this was very good. We have to look at the graph because unfortunately I'm actually accepting my fault. I only look at the values. I actually don't look at the graphs because I need to still understand it. But basically we are supposed to look at the R5, we are supposed to look at R20, R5 minus R20 and then the AX triangle. And then we are supposed to look at the coherence, which has to be 7. And the post bronchodilator coherence should also be 7.
More than 7. More than 7 is accepted.
Yes.
Okay. Any other input from anybody? What else to look at, or any other pattern to look at?
Resonant frequency, that line, if it is more and right, it comes to left with good bronchodilation. That you must remember and look at. That is very simple.
Wow. I think this was really good. Any other additions from anybody?
Okay.
Okay,
Yeah,
so
we can actually customize the report the way we want. That is what I have done for most of my reports. So it starts with like report date, time, coherence coefficient for 5 hours, coherence coefficient for 20 hours. Then comes R5, R20, difference of R5 minus 20, resonance frequency, area under area of reactance, and X5. Finally, X5. X5 is the most fragile component of the spirometry, I feel. It is more like FEF 75-25. To be used last. And finally, I have decided to include both difference of X5 in inspiratory and expiratory after reading today. So that is one parameter which is going to be added to the report by tomorrow or day after tomorrow.
Okay, great.
Very
So
nice.
quick questions. I'm taking audience questions along with my questions. So Dr. Nitin, coming to you, quick answers. Can we get false positives or false negatives for obstructive airway disease in oscillometry, number one? And the second, this is a very interesting question by Dr. Suyash Patil from our Pune, Maharashtra. Any contraindications of iOS? Just take them quickly.
Yeah, I think I've seen false positives number of times, but the clinical scenario sorts it out. So I think most of the times you are not, and the change is never like dramatic 40%, 100%, 60%. So I think that is not the problem really. False negatives, I have seen very tiny number, but I have seen them. And when there is a reversibility and when there is a clinically relevant asthma, I have seen them. So I think no test in the world is perfect. So I think we'll have to take every test with a pinch of salt. But I think, and with a good performance, good coherence value, good attempt, the person has done a good spirometry, has shown a reversibility, and has still not shown abnormal abnormal FOT or airway iOS in my situation. But I think leave that apart. And the second part you said was contraindication. I think we have touched upon all those, ranging from aneurysm to the third trimester of pregnancy avoidable to so on and so forth. So I think.
If I can come over here.
There are no contraindications, right? I believe. No contraindications to oscillometry, right?
No. I have taken patients from ICU on oxygen and done comfortable iOS.
Basically, iOS has been reported in children from 2 years of age.
Yeah,
so maybe less than 2 years of age may not be possible. 2 years and more has been done. Yes, Dr. Salvi.
And can be done even in ventilated patients.
Yeah. So Amita, this was a question that was asked to me. And I said, what is the contraindication for normal tidal breathing?
Breathing.
Exactly.
If there is no contraindication for breathing, there is no contraindication. Only contraindication can be bronchodilator allergy or hypersensitivity. So that will be for bronchodilator response and not for iOS per se.
Spirometry has 21 contraindications. So there are about 7 or 8 absolute, and the remaining are relative contraindications.
So Amita
has got no contraindications.
Yes.
Just one point. One is that the person has to do a tidal breathing. Sometimes if they breathe very fast, that may cause actually a collapse of the smaller airways and give a false positive in that. Secondly, in institutes where there is both the oscillometry as well as the spirometry, one should see to it that the it should not be the other way around.
Very important point, Salil, because I mean, if you're asking both for the patient, oscillometry has to be done before the spirometry, otherwise the advantage is lost. Very important point, very well put by Salil. Salil, coming to you right now. So what are the fallacies of, in which conditions PFT may miss obstruction, but iOS will pick it up?
See, as we have all been discussing for last 2 hours, oscillometry is a very sensitive test for small airways, okay, compared to even a spirometry, a conventional spirometry. I mean, the basis stands, and whatever the physiology is explained picks up at a very early stage. Whenever, in fact, in some cases, the spirometry come normal, it is the oscillometry which may pick up. So whatever the terms we call as pre-COPD or maybe even the prisms which we have, those are places where oscillometry would be those tests which will, and in fact, I heard in one Dr. Salvi's talk only, when that twin tower blast had taken place and they had done a study of spirometry, they found that spirometry had come normal, but the oscillometry had picked up the small airway diseases. So we have got ample evidence now to know that.
So I basically feel that in the history suggests obstructive airway disease, but the spirometry comes normal. Oscillometry up early
definitely
obstruction, especially with smokers and people with exposure. And I feel cough variant asthma, we are often getting no reversibility on PFT, but oscillometry is showing. So I think maybe for cough variant asthma.
Yes, even that place. Yes, absolutely.
Right.
Absolutely. Yeah.
Coming to Dr. Lakshmikant. So we've done we've done oscillometry and we've confirmed obstruction. Now, when to repeat it again? And does it have any role in assessing response to treatment?
Yeah, response to treatment has been studied in asthma more than COPD. And the response is again documented by decreased resistance, on subsequent impulse oscillometry and decrease area under reactance in COPD. So this is one classical difference. Though both are airway diseases, even when you are trying to make a diagnosis, when you are trying to diagnose a COPD on impulse oscillometry, you are more interested in area under area of reactance, AX, rather than actual resistance, because many times resistance you can get even normal in COPD, but AX is very huge. And on the contrary, AX and airway resistance goes hand in hand in patients with asthma. Repetition has not been documented per protocol, but something like about 8 weeks, 8 to 12 weeks is what is considered if you really want to look for the delayed response or the clinical improvement, as we do for the FEC or FEV1. But we do not have very clear guidance on this at the moment.
So I believe just like PFT, maybe we would repeat at 3 months. I think that would be correct, I just want to say one thing about false positive. We asked, what about oscillometry showing false positive obstruction? So I think if the patient is allergic rhinitis, then also the resistance may increase. So I feel that in the presence of allergic rhinitis, if clinically it's not fitting, we should not be diagnosing obstructive airway disease just based on the R5 values.
But for all you know, it may be asthma in evolution, and the symptoms may come after another 5 months or 6 months of untreated allergic rhinitis because it is known. So, 1/3 of the AR eventually becomes asthma is the history. It's something which is well documented. So I think
the point to be taken is that allergic rhinitis also increases resistance, so that we should know about. I'm coming to Dr. Salvi.
Not really, because you are anyway bypassing the nose when you are doing impulse oscillometry. You are just using it in the oral cavity. If at all it has to increase the resistance, it has to increase the central airway resistance. That is R20 will be more. And it may be because of something like adenoids or tonsils, which are significantly enlarged, or maybe vocal cord edema, which is there simultaneously. But allergic rhinitis per se, which is not causing any pathology beyond the soft palate, I don't think there is any reason for it to give rise to false positivity.
I would like to have one more comment. Allergic rhinitis is found in almost 70% of asthmatic. And that's why we just do peak flow metry in these patients who have allergic rhinitis, family history of asthma, and give the peak flow for a couple of days to patient, ask him to record about 3 to 4 times a day. So wide variation over short period of time in intrapulmonary resistance, yes, if it is there, patient has asthma. And then that should be documented with either spirometry or with oscillometry.
Right. Very good. So now I'm just taking questions from everybody. So we have Dr. Sunil Narute. In fact, he's done his DNB with us. So very interesting question by Dr. Sunil. He's asking that just like spirometry, in oscillometry, do we have reproducibility and acceptability criteria? And before we read the report, what should we look at to decide if this report is to be read or not? So Dr. Salvi, to you.
Yeah. So that is what coherence is all about. So both Dr. Nitin Abhyankar and Dr. Bardapurkar have been talking about it. So before you do the interpretation, look at coherence. Coherence is reproducibility. Okay. Now the acceptability criteria, there's no graph that tells you whether this is an acceptable test or not. So you have to rely on the technical person who's doing the test. Did the person do normal tidal breathing? Because it's sometimes when it asks the patient to do normal tidal breathing, which is 500 ml, they will do 801 liter breathing. Now that is going to mess up all the oscillometry values. Now that unfortunately cannot be picked up on the graph because there's no graph that we get, unlike what we get in spirometry. But we do get tidal volume numbers in oscillometry. So look at the tidal volume. If it is between 350 to 500, then you're confident that this was the normal tidal breathing. It should not be shallow breathing. It should not be deep breathing as well. So that comes with a visual, looking at the patient while performing the test. Has the patient coughed during the test? Is there a glottic closure? You get very classical patterns on the screen when you're doing the test. But there's no representation of that in the report. So all this has to be taught to the technician about acceptability, which is no cough, no glottic closure, normal tidal volumes. Sometimes they do irregular breathing, fast breathing, slow breathing, fast breathing. That should not happen. So that is all picked up visually. And reproducibility is picked up on coherence. So coherence is reproducible.
I think your technicians will tell you often that the patient protrudes its tongue into the mouthpiece and blocks it. And in fact, a good technician picks it up and corrects it. So I think what technicians are doing is very important, finally.
What should be the coherence?
And the software itself has inherent quality control criteria. It takes average of 3 readings. It takes 3 readings and then it takes average of 3 readings. And 3 acceptable manuals are selected randomly over a test period. And then only the software gives that the test is acceptable. And the second important check for us to look at is correlation coefficient.
So what should be the value of that up to what is acceptable? The
So coherence is,
More than 0.7.
actually it should be 0.8, 0.9.
1% at a
0.8
time.
and 0.9.
0.8 and 0.9.
Yeah.
Yes. Okay,
Yeah, 0.8 for
R5 and 0.9 for R20.
Wonderful.
20.
So this is very, very important. Great. Dr. Sarindranath Banerjee asked us about kindly enlighten how to diagnose conditions by iOS. We've already done it. We have a dear friend, Dr. Nikhil from Bombay. So he said, Dr. Salvi, Dr. Amita, great talk, great panel discussion. Do you foresee iOS replacing or evolving as a substitute to spirometry in clinical practice in near future? Dr. Lakshmikant, you answer, because what is your answer to that?
Yeah, it will only complement. None of the tests will actually take away the gold standard. It will definitely complement and take up its space in subset of patients where spirometry either is contraindicated or not able to give us the information, or patient is not able to perform.
Fantastic. They are complementing but not replacing each other. We have to do both. Dr. Alpa, my dear friend, Dr. Alpa Dalal from Bombay, Dr. Varda Kurpar, for you, she's asking, does small airway obstruction in iOS correlate with air trapping and airway resistance on body box analysis?
No, I don't do body box analysis. Just look at the small airways, R5 minus R20. If it is more than 1, shows good reversibility, the improvement by 40%. I say this is small airway reversible disease, which we can also get in asthma, as well as we can get this also in COPD. So history is very important. Clinical examination is also important. And what we do impulse as well as we do spirometry. And we just look at both the reports and then give.
Okay, fine. So air trapping is something that we can't really go by definitely on impulse oscillometry, correct? But with history and everything, we can definitely say whether there's obstruction or not. Okay, Dr. Arjun Khanna from Delhi, a very good friend. Dr. Salvi, for you, what is the importance of X5 and X20?
Oh, good. So X20, I don't think anybody has found any reasonably good application in clinical practice, but I think it's just a matter of time. We will, at some point of time, we will find some signal. X20 is giving us a little useful information about this component of the respiratory function. As of now,
no,
not reported.
Okay.
Very unlikely to be of useful, sir. Looking at the physiology and the physics of it, it is extremely unlikely to be of useful unless we are trying to look at something like EDAC or expiratory dynamic airway collapse, or maybe mucus plugs, or variable vocal cord dysfunction. These are the things where it may actually be of some clinical significance. But again, they are not something which give a consistent pattern. So may not be of very use.
Yeah, so X20 is the inertance properties of the lung, which is the weight of the air column.
So we have very small air column which can actually sort of modulate that parameter. So unless we have parameters which can modulate that particular factor, it is unlikely to be of much clinical significance.
Okay, coming to Dr. Salil, there's an interesting question by our friend Dr. Darshan Bajaj. He's an excellent answer. Okay, so the question to you, Dr. Salil, can there be any situation where history-wise and on clinical examination patient has obstructive airway disease, but oscillometry will come normal?
Unlikely, because we have got a history. We have taken I don't think so. I mean, let us put this question to others where it comes normal and history suggests you of obstructive airway disease.
I have seen that, but rarely. Very,
Very
very,
rare. I don't.
very small numbers.
In fact,
We have nearly done around 1,000, and I have seen a 2 or 3 handfuls where we could get this.
I would say that look at the coherence and just look at the tidal volume graph as we discussed before, because we are suspecting ideally we should get, and probably on bronchodilator, at least the resistance will drop. If it's not abnormal, at least it will become more normal after bronchodilator probably. But interesting question. So now, Dr. Nitin, to you. Any comment on tidal volume related changes in iOS report? How to notice gulping, swallowing, vocal cord, glottic closure abnormality in oscillogram?
All these are, technician dependent measures, and there are going to be some patients who will hyperventilate irrespective of whatever the training you give them. So, then their tidal volumes are like something like 600, 700, 800, and that is what we don't want. We also do not want, as Salvi said, somebody with 100 ml tidal volume. So your target is maybe anywhere between 350 to 500 max to max. So I think that is the right zone that we are looking at. And a good trained technician is able to get this out of the patient without much difficulty, because it's a normal tidal breathing at the end of the day. And it's like, it's like yoga training where it's breathe calmly, breathe more comfortably. And I think things will fall in place. Take your tongue inside. So, those simple messages which keeps on giving while the test is being done. And it's not for many hours. It's a few seconds. So 30 seconds, 35 seconds. People are able to do it.
Great. So the tidal volume graph has to be seen and our technician has to be really watchful. So that is important. Coming to Dr. Salvi, interesting question by Dr. Bhavya from Mumbai. How to grade severity of obstruction or restriction is mild, moderate, severe based on oscillometry report, and how to objectively assess worsening or improvement in follow-up oscillometry?
Very good question. So classification of mild, moderate, severe on oscillometry is evolving. As of now, like we have fixed, we have a very standard values for spirometry. Mild, moderate, severe for asthma is 60-80 rule. For COPD is the 30-50-80 rule. That is still evolving in oscillometry. There are about 3 or 4 publications that have started suggesting cutoff values, but they're quite different from each other. So let's not believe that they'll all come together and have one common value. But over a period of time, we will get those cutoff values for mild, moderate, severe. From a follow-up point of view, which parameter do I believe will be the most useful one for asthma and for COPD? R5 is a good parameter. If you look at follow-up R5 values, R5 minus R20 will tell you about small airways, and especially from a COPD point of view. And I don't know, I like X5, although Lakshmikant says that X5 is the little crazy one, like FEF 25 to 75. But I think X5 also gives you reasonably good information about what is happening, especially in the distal portion of the lung, the small areas. So R5 minus R20 and X5. AX, I will look for from a bronchodilator perspective rather than a follow-up perspective.
So Dr. Arjun had asked us about the role of X5, Dr. Salvi. So you think X5 is useful?
I believe so. I mean, Lakshmikant, I know Lakshmikant has a different thought, but maybe Dr.
I did not say. Yeah.
Everyone in the world agrees that the Goldman triangle is the best, and it is the lowest point of the triangle X5. So that has to be also good to look at.
Basically, if X5 is not normal, then would it indicate small airway obstruction?
Look at the
normal says more negative. If X5 becomes more negative, then X5 becomes more negative in a whole host
can
of
be
other
because of 2 things. One is the restriction also will give X5, which is on a much negative side, as well as the severe obstruction. Basically, wherever we are thinking that the alveoli are over distended, they have a tendency to come back to normal with greater rebound. That is what X5 represents.
Correct. You're right. Absolutely right. So X5 is a very generic parameter. It gives you a generic information about what is happening in the distal portion of the lung. Now, to tease out the very specific components of that, look at X5 inspiratory, look at X5 expiratory, look at X5 end inspiratory, look at X5 end expiratory. I think that knowledge is still evolving, but I'm very excited about this because it is showing some very good signals. So the machine that we have should be able to give us these parameters also.
Okay, great.
No,
Now,
but machines give mild, moderate, severe severity grading based on only one study which they have incorporated in the automatic reporting algorithm, which is centrisuit of the Jaeger. However, that is not very reliable. So at the moment, I think it is better we not go by that criteria. Even if it is there, we can just keep it away from the report. So I have not included that in my report.
So one more advantage of spirometry over oscillometry is that we can make the disease into, classify it as per the severity. We have
grading severity spirometry is the only way.
Yes. Coming to Dr. Bardapurkar, we have from our Dr. Amit from Mumbai, there are two questions. The first one is already answered. Will oscillometry replace spirometry? We all have said they are complementary. The second question Dr. Amit is asking is, what is the indication of oscillometry after spirometry?
So the spirometry, the maneuver has to be, patient has to take a deep breath and blow as fast as he can or she can. That can affect the airways, and that is why the rule is do first oscillometry or FOT and then do spirometry. So the effort or the pressure inside the thorax might change the iOS readings.
No, I think he's asking that if you already done spirometry, then in which patients you'll think of in addition doing oscillometry, probably at a different day?
Oh, yes. Say patient of asthma, and you do spirometry, he's under your treatment. Patient says, still I got cough in the night, I get breathlessness, and spirometry is absolutely normal. Do this, you will definitely find small airway obstruction, which is good reversible. So use the Foster inhaler or Nivoli, particularly, which will target the small airways.
And basically, you're suspecting obstructive airway disease clinically, and if spirometry comes normal and does not even show bronchodilator reversibility, then earlier we used to do methacholine challenge testing. I think instead of doing that, probably we can do oscillometry.
Yes.
Yes. Say something. Yes.
Yeah, the future of asthma, Amita, is the phenotype of small airways disease.
Correct.
So SAD asthma is going to be a very important clinical phenotype that is going to receive a lot of recognition, because there are now drugs available that specifically target the small airways. So if you have a patient of asthma whose spirometry is normal, or for that matter, spirometry shows presence of asthma, but the patient has got predominantly nighttime symptoms, other features that suggest small airways obstruction, I would most certainly do oscillometry after spirometry, because I want to check whether this is predominantly SAD asthma or with this is not SAD asthma, because that is going to decide my future pharmacotherapy. So I think that is going to be a very, very important application in the future.
Great.
One more point I'll tell you. In obesity, means people who are overweight, high BMI, in them also our conventional spirometry may only show a restriction because of the fat and because of the difficulty for the lung to inflate it. Always show a small airway if it is there. So in those patients also, oscillometry has shown a significant good small airway obstruction.
Excellent. Dr. Shivani from Mumbai, again, a very important question. We've covered it, but I'll still say, she said any use of coherence in iOS. Dr. Lakshmikant, can you repeat? We already said it, but what is the use of coherence?
Yeah, 0.8 and 0.9. For R5, 0.8, more than 0.8 it should be, and for R20 it should be more than 0.9.
Yeah, and otherwise the test is not acceptable, right?
Yeah, coherence measures reproducibility. It is equal to reproducibility. If your R5 value is this much, how reproducible are those values? But in addition to that, you have to look at acceptability as well, which is not there present in the report.
Correct. And this coherence, we have to look at bronchodilator, pre and post, both bronchodilator, right? Correct. Great.
Yeah.
Interesting question, Dr. Salvi, to you from our dear friend Dr. Gyan Chakra Mishra from Nagpur. We've covered everything, but still I'll repeat the question. If FOT does not have reference values, but only cutoff values, then it can be used for diagnosis only probably. Very important point. Any references for severity grading of obstruction or restriction, or should we rely on patients' baseline values only for comparison on follow-up? Can lack of severity classification probably limit its role on treatment titration in follow-up?
Okay, very good question. So the first one is about cutoff values versus predicted values. The fact that in adults, age, gender, height makes very little difference to the predicted equation. This is a unique advantage of oscillometry over other spirometry. And I believe, this is one property which is going to make oscillometry very user-friendly. You don't need an equation, especially in the adults. So I'm not looking at it as a disadvantage, but I'm looking at it as an advantage in clinical practice. Second is with regard to classification of severity. The science is still evolving, and until we generate that data ourselves in our own country, we should not categorize our patients into mild, moderate, severe as of now on oscillometry. That time is yet to come. Third is follow-up. I think it's a very useful tool, more sensitive tool for follow-up than what spirometry does. But the confidence in that will only come as we get more and more research studies published to show that if your R5 value improves by so and so, it's a very good improvement compared to what maybe FEV1 or other parameters. So overall, I think the science is still evolving, and I genuinely believe, and I'm very passionate about this, India can play a lead role in oscillometry globally. We are one of those few countries where oscillometry is now picking up. US oscillometry is not popular. In many European countries, it is not popular. It is only now UK has started understanding the value of oscillometry. Australia has started understanding the value of oscillometry. We are in the right place at the right time. So if we put all our act together and we generate quality data from our country, India will be the country that will showcase to the world what are the cutoff values, what are the severity classification, what is good bronchodilator reversibility. All that data must come from India. It is all possible now.
Correct.
I just had one comment, sir. Actually, I reserved it. I was planning to ask you later, but since you have raised a very important topic of being a leader here, I want to ask this. In your research of Dr. Vanzari, you studied height from 140 to going up to 190 centimeter, where you found that the only better correlation was with the height. And we have a huge difference in the resistance, which is dropping from year 3 going back to the year 15. So I have a very naive question, whether this resistance drop is actually related to age or is actually related to increasing height. The reason being that in your review, which you published way back in 2015-16, you said that the height is the most important parameter which actually takes the resistance and the other parameters haywire. So most important influence in that review was told to be more than 60% contribution comes from the height alone, and other parameters do not contribute much. So if that is so, possibly even age will go away and age-specific criteria may not be required.
Very good. So the 60% that I was talking about was within all the parameters that make some impact on your predicted value. Overall, if you see what is the unique, if you take only height, it contributes to around 20-25%. Age contributes to only about 10-12%.
Yeah, so the point here is, sir, you studied height starting from 140 to 190.
Correct. That's
so
the Indian
for 3 years, the height will go from something like 30-35 centimeter to 140 centimeters. So the difference here is more than almost a meter.
So this is only for an adult population.
So I'm sorry to interrupt. We have, without exaggeration, 43 more questions pending, and people are typing more and more. I just feel quickly in 20 minutes, I'm just trying to scan. This is really overwhelming. More and more messages are just coming.
I think we'll have to wind up this getting too late.
So so we have Dr. Dhanmurthy Koppu. Question to Dr. Bardapurkar.
Yes.
I think this is very important. I have purposely taken this question. What is the cost of the better iOS machine available in India? And what's the average charge per test that we should normally keep?
See, I'm using the Thoracis, which is from Canada. It costs 10 lakh rupees. And we are charging 2,000 rupees for each test.
Okay, fine.
And the entire of Bangalore, that has been installed for the research, we do it freely.
Oh, wonderful. How much does that cost, that machine? from Bangalore?
It costs around 3 lakh rupees.
About 3 lakhs. But
So
there
if we were to tell people, what would we recommend them to buy? Because it's a direct question. Okay, go
What, Amita, our strategy is to do a spirometry and iOS together always and charge 2,000 rupees put together.
So which machine to buy would we tell them?
We have a wire machine, but I think a good FOT machine is as good as a wire machine. That's what I feel.
Okay, fine. This question now to Dr. Lakshmikant. Dr. Subhankar Chakravarti from Delhi is asking, in ILD, we measure serial FPC values for prognostication. In iOS, which parameter to follow up? So for ILD, and I'm asking for obstructive airway disease.
We have no cutoffs. We have no values to go by at the moment. We'll have to still do FEC for serial monitoring. If they're not able to do FEC, we'll have to go by other parameters.
Okay, we have Dr. Rohit.
For monitoring, I'm not using iOS at all. Even for obstructive airway disease, I'm not using iOS so far for monitoring. Yes, it is useful for some subset of patients. Yes, I'm not denying that, but I have not yet started using it for the monitoring response to treatment or repetition. So iOS largely is done only once for most of my patients for clearing the diagnosis.
We have Dr. Rohit Joshi, who's currently doing his DNB with us. Very, very bright, very intelligent. Dr. Salvi, I'm coming to you again because you are the one who'll answer this. Though we've covered once again how to diagnose restrictive lung diseases with oscillometry.
So X5 end inspiratory, X5 expiratory, X5 inspiratory. I think that is good enough that is what more specificity than other parameters. R5 resonant frequency is another parameter that sorts of increases in interstitial lung disease, but it's X5 inspiratory, X5 expiratory.
Okay, Dr. Salil, I can't see. Dr. Nitin, I'll come to you. Dr. Bharat Toshniwala, dear friend from Nanded, he's asking, again, we've covered this, but still, the basic difference between FOT and iOS and which one to prefer in a cost and resource limited setting.
I think the cost, if you look at, then FOT is definitely the correct way to go ahead. I don't have any hesitation in recommending that. Plus the fact that, you have a very good resource like CREST, which is doing a lot of work on FOT also. So I think you have something to go by. And that is, I think that's, we can link up with them. And in fact, that's what we are also in the process of tying up with them. Bardapurkar sir is doing already that. So I think FOT is a better buy from the cost sense of it. But if in a big corporate hospital, when we are buying things from on a whole thing, we have a cardiopulmonary exercise testing range, pura range hai. So usme, I think iOS comes as a part of the package, and it's iOS is not bad. It's not a bad test at all.
I have one thing to say. In FOT, we have to do it multiple times. So sometimes it may just happen that patient gets tired and some of the values may not come correct. I'm thinking.
Not really. I don't think that's a problem.
That is a misnomer. FOT is not forceful test. FOT forced oscillation is the sound waves which are going forcefully. Patient doesn't have to put in effort. The tests are done same.
Would it be that FOT is more time consuming? So if you have huge numbers,
time consuming.
No, but I just feel that if you have huge numbers, then in FOT you may spend more time and you can cover up by doing more iOSs. And in the long term, if you have huge numbers, then the cost doesn't become a problem.
So there is no budget limit, then go for iOS. If there is a budget limit, go for FOT. It's a more cost sensible buy.
So Salil, coming to you, we have a very interesting question from Dr. Sangeeta Priya from Tamil Nadu. Coimbatore, she is asking what is the role of iOS in PRISM group of patients? I think excellent question.
But this we have discussed by now, all these things about early diagnosis, early picking up of small airway obstruction in patients where the FE1, FVC is more than post-bronchodilator, more than 70, but we are suspecting or he's a smoker or exposed to smoking, occupational, and oscillometry is done. There are very good chances that we'll pick up the oscillometry will pick up early changes where the spirometry has come normal. So I think we have discussed this.
Yes. Coming to Dr. Bardapurkar, Dr. Jaykumar Mehta has asked 2 questions from Ahmedabad. Please guide us about tidal volume based inferences and what variation in tidal volume between pre and post can be considered acceptable?
No, the routinely tidal volume which patient does for before and after bronchodilator, there is no change.
Okay, fine. Great. Point well taken. So no change. Tidal volume has to be between 350 and 500 both the times. Dr. Salvi, to you, we have Dr. Harish. He did his DNB exams with us. Very, very intelligent. So he's asking, is there any role of iOS in demonstrating bronchiolitis in connective tissue disease, cough variant asthma, or such illnesses? Very good question.
Bronchiolitis, yes. There are a couple of papers that have been published more recently. Oscillometry also shows changes of COVID-19 pneumonia. So there are lots of papers and abstracts that have been presented in the last 1 or 2 years. Connective tissue disease, so that would be considered an interstitial lung disease, isn't it? So early interstitial lung disease showing you ILD type of a pattern. Yes, oscillometry would pick that up as well.
Wonderful. So, I'm just now going to take 3 to 4 questions which have been there for a very long time. So, Dr. Nitin, coming to you, Dr. Vishal Arya, he's a good friend of all of us. He's asked actually 4 or 5 questions, asking you all together. What about using iOS in goiter patients? Anything?
I wouldn't have any.
Okay, how to calibrate iOS? So, goiter patients, nothing. What if it's external goiter? Any changes?
No.
Okay, nothing. Fine. How do we calibrate? Sorry?
Central airway resistance.
Yeah.
Okay,
if
fine.
it is causing central airway obstruction, it will lead to central airway resistance. Increase central airway resistance.
It's not a contraindication.
Right. Okay, he's also asking how to calibrate iOS machine.
I don't know, very frankly.
There is a calibration protocol.
Yes.
There is a fixed resistance.
Right. Dr. Vishal has asked this very interesting question. I'll ask Dr. Salvi, can iOS help in patients who are being planned for lobectomy as pre-surgery investigation?
Not that I'm aware of any paper that has shown any value for that, but maybe potentially yes, but there is no evidence as of now.
As of now, no evidence.
Okay, Dr. Kalpesh Gandhi from Jalgaon, our dear friend, he's asking, is there any difference between iOS reporting by thoracic and Antalya machine? To Dr. Bardapurkar.
See, I said initially, iOS by, say, Canada machine has AX values given very significantly. But in my Antalya, there are no AX values. And this I discussed with the company people. They said that they are coming out with AX values in that machine. Otherwise, there is no difference. And AX is very important, not only in COPD, but asthma also. Small airway disease, what we call as SAD, is very important part of impulse oscillometry.
So the Antlia old device has frequencies from 5 to 20. If your if your resonant frequency is above 20, then you will not get an area of reactance. And therefore that Antlia Plus, which is a new device that they're about to launch, that has got frequencies up to 35. So that will give you all the area of reactance that is required.
You are mute, ma'am.
Amita, you're muted.
I'm sorry. Dr. Ravi Dosi, our dear friend from Madhya Pradesh. Nitin, for you, any contraindication like smoking or coffee before iOS like we have for spirometry?
I think the same kind of precautions you would recommend. No bronchodilators. Tea has a bronchodilatory property more than coffee, so I would avoid tea before it. But I think it will be very similar to what I'm recommending for a spirometry.
I agree, Dr. Salvi. Probably the same contraindications. No major exercise, no major meal. Major meal might be allowed its tidal volume probably. So.
Yeah, because here is normal tidal breathing. So
correct.
Meal, no. Smoking, yes. Tea, coffee, yes. These are the two main ones. I don't think anything more than that.
Correct. We have our senior physician, Dr. Meena Hingorani. Dr. Lakshmikant, for you, for smoking cessation on spirometry, we convince a smoker showing lung age. How do we convince on impulse oscillometry about smoking cessation?
Impulse oscillometry is going to be more important to scare the patients because it is going to show up the abnormalities more commonly than the spirometry. The spirometry may actually reinforce them to continue smoking. So far, the lung damage has not happened. In impulse oscillometry, something will be abnormal definitely to show the patients.
Nearly 10 to 15 years, the spirometry may remain normal. for the first, yeah, and
Salil, are you around? I'm going to ask the last question. We have Dr. Ashish here from Thane, Mumbai. He's asking two questions. Will higher strength of ICS plus LABA be useful in small airway disease asthma? Would cyclosinide be a good ICS option? And second question, role of impulse oscillometry in evaluating disease severity and predicting airway reversibility in patients with bronchiectasis. Two very good questions. I'm not taking any more questions after this.
So see, regarding ICS lava, I don't think we take only spirometry. We are going to take the clinical understanding, stable COPD, exacerbation. Many things will come into picture. Oscillometry values, of course, will matter. But then, as Dr. Bhadrakur was also saying, if we are talking of small airway obstruction, then the extra fine particulate inhaled corticosteroid would be a better option, or the molecule to be used through a meter dose inhaler with a spacer, and that would be answering that part of the question. And second aspect is about bronchiectasis. Now, bronchiectasis would be a mixed picture. It will have some element of obstruction, some element of restriction as well. So we would get a picture where there would be a large airway also, there would be a small airway also, plus the X5 would also be affected. Now we are going to take into picture the X5 inspiratory, expiratory. So all the parameters will have to be put. But I think bronchiectasis is going to be diagnosed naturally by history, naturally by an X-ray picture. And the oscillometry will tell us more or less the physiological alterations which are happening. We are not going to diagnose bronchiectasis based on oscillometry.
No, excellent. One more suggestion. I just feel that very often patients on bronchiectasis, on PFT, they don't show reversibility. Probably on oscillometry, if they show, then it may justify the use of inhaled corticosteroids, because sometimes people are uncomfortable using inhaled corticosteroids in bronchiectasis for the fear of infection. But I kind of feel that probably if oscillometry shows reversibility, despite they being on optimum bronchodilators, then probably adding ICS would be justified.
Yeah. Okay, so phenotype would be more important, ma'am. Rather than even showing reversibility, phenotype would be more important.
Yeah, but bronchiectasis sometimes, like post-TB bronchiectasis or, post-infective bronchiectasis.
Yeah, even then, possibly eosinophils increased or pheno increased may form a better basis for using inhaled corticosteroids than reversibility.
May not, right. Okay, excellent. I think we've had a fantastic session. We've gone on for 3 hours actually, and we still have about 22 questions which I've not taken. I'm very, very sorry. Maybe we'll do another webinar.
Another session.
Okay, but a last thing. I want everybody to say one important point about oscillometry, which will make a difference to what others are believing. Starting from Dr. Vardapurkar.
When you are doing impulse oscillometry, always do spirometry, because spirometry has taught you, but impulse oscillometry is teaching you still.
Very well said, Dr. Salvi.
Yeah, I think oscillometry is the future of lung function testing. India has a tremendous opportunity to generate knowledge that where we could lead the world. So it's important for us to realize that and start working towards it.
You please send us what we have to send our data to. We all are going to send all our data.
Sure.
Dr. Lakshmikant, what would you like to say?
Yeah, the iOS is still, even after 50 or 70 years of its origin, it is still in infancy. We have a lot to learn, and possibly we have a lot to generate before we can make solid recommendations.
Great. Dr. Nitin?
I think, but the beginning has been made and it's arriving, though we still have a way to go ahead, but I think the next decade belongs to iOS or airway oscillometry, whatever you want to call it.
Salil, you tell us, please.
Yeah, so I will end it like this, that today is Father's Day. Okay. So if we consider oscillometry as the father, then spirometry is the grandfather, and grandfather is always wiser than the father.
Very well said. Okay, so a huge big thank you, Dr. Salvi, for the fantastic masterclass. And a huge big thank you to Dr. Vardapurkar, Dr. Nitin, Dr. Lakshmikant, and dear Salil for excellent information, excellent discussion. And a huge big thank you to all our audience for still typing while I'm talking. One question just got typed. So thank you so much. It was just wonderful. I've learned so much. I really have learned so much. And so many things which were not correct in my mind have been corrected. And now I'm going to start looking at the graph also, which I wasn't. So thank you very much. It has been really great. And a big thank you to Maharashtra chapter of Indian Chess Society for initiating this. And we are going to come back very soon with another webinar, which is going to be equally interesting. Thank you very much. A big thank you to Cipla for helping us, providing us with a platform. Okay.
Thank you.
Good night.
Thank you, Amita. Thank you, Amita, for going on with the energy throughout the session. Thank you so much.
Thank you. I enjoyed it.
Absolutely amazing, Amita. I can't believe we did it for 3 hours.
Yeah, 3 hours and questions are still being typed. It's wonderful.
Bye.